Yeah, good
Hi
evening,
Ajay.
everybody, and welcome to this webinar by the Renal Transplant Cell of the Urological Society of India. It's the Urological Society and the Indian School of Urology initiative. Today we have the Disease Donor Organ Retrieval Workshop, which is very nicely crafted by Dr. Ajay Oswal, who is the convener of the Renal Transplant Cell. We have quite good, interesting videos on the organ retrieval, so it will be interesting to watch this session. With this introduction, I would now invite Professor Mallikarjun, President of the Urological Society of India, to give his opening remarks. Over to you, Dr. Mallikarjun.
Thank you, Keshav. It's a great evening today. Thank everybody. There's so much of varied faculty on renal transplant program I could see, and Ajay has crafted a great program today regarding the organ retrieval workshop. Actually, in fact, we've been doing it in the MS Ramaya on the cadavers all these days, and possibly at this point, at this moment, it is not possible. And we are hopeful that we'll be able to emulate something and carry out amount of knowledge to the juniors and on to the residents. Thank you very much for this opportunity, Keshav, and I think all the best to the workshop and all the best to Ajay.
Thank you, Dr. Mallikarjun. Now I would invite Dr. Rajesh Sood, who is the chairman of the Indian School of Urology, for his opening remarks. Over to you, Dr. Rajiv.
Thank you, Dr. Keshav, President Dr. Mallikarjun, and all the esteemed faculty. I am thankful to Dr. Ajay Oswal for crafting such a great program, well crafted, and also it is the continuation of our ongoing renal transplant subspecialty programs, and very important topic has been taken today: diseased donor organ retrieval workshop. You know that in this corona period, recently in India, the cadaveric transplant especially, and in general, the transplant program, live donor also has got affected. Many institutions were not doing. I am from Delhi, and in Delhi, the number of transplants has gone significantly down. And now today we will be talking about a retrieval workshop where various topics are covered by video workshops and are followed by short lectures. And with this, movement of a subspecialty based functioning of Urological Society of India is well taken forward by this subspecialty cell led by Dr. Ajay Oswal, Vasudevan, Jamal Rizvi, Vikas Jain, and Sanjay Surekha. And we have Pranjal Modi, Sunil Shroff, and Vatsala Trivedi today as experts. And from US, we have expert faculty from USA and UK. Dr. Matthew is there, Dr. Puneet Sindhwani, Randeep Kashyap is there, and from UK, Sanjay Sinha is there. Now, with the Indian faculty chipping in, Dr. Anurag Singhal, Sujata Patwardhan, Swaminathan, and Vasanti Ramesh, who is looking after the NATO program, they all will be giving their views and also what all is happening. But one thing is for sure that more and more centers in India are now taking up the cadaveric program. Government is very serious. The urological society is also very seriously taking up this program. Now the centers where renal transplant is not there, they are not getting approved in the new curriculum criterias and in the era of competency based education and competency based training, which is coming in by through National Medical Commission newly set up. It is now
I think Rajiv lost his correction, Keshav.
Yeah, I think Rajiv has lost his connection. So we move on, we'll not waste time. I will now invite Dr. Ajay Oswal, the convener of the cell, to take over and moderate the session. Over to you, Dr. Ajay.
Good evening, respected teachers and dear friends. I welcome all of you to this important session in the ongoing journey of USI. Retrieval from disease donors is an extremely crucial operation, and it is imperative that all young urologists learn how to retrieve the organs from the deceased donors. With that aim in mind, this program has been crafted. So without wasting much time, I invite Professor Kashyap from University of Rochester, New York, to start his presentation. Dr. Kashyap has been basically trained in India, and then he moved on to USA, and at present he is the director of abdominal organ transplant programs at University of Rochester, USA. Over to you, Dr. Kashyap.
Thank you, Dr. Oswal, for the kind introduction, and thank you to the organizing committee for inviting me to be presenting today. I'll share my screen now. Everybody can see the screen?
Yes, sir.
Thank you. I just, before I start my talk, brief perspective of our institution. We are a university-based hospital in upstate New York, about 300 miles to the west of New York City. And we are one of the only hospitals in upstate New York that performs disease donor kidney transplants for liver, kidney, heart, and pancreas. And we do about 200 transplants a year, and majority of them are disease donors. And we are also one of the 5 programs in the US who do robotic kidney transplants for both donors and recipients. So I've been in transplant for a long time, and I've liked a lot of these operations. But this multi-organ procurement is still one of my favorite cases. And there are a number of reasons why I say that. One, it's a great teaching case for all our residents and fellows who do transplant rotations from different subspecialties. And it's they get to see this case, they get to learn from this case, and they apply the principles that they've learned from this surgery in their specialties, because in this one operation, there are multiple operations that are embedded. And you kind of learn different steps of hepatectomies, such as nephrectomy, removing pancreas, steps of the pancreas operation, and steps of gastrectomy, exposure of CBD, exposure of retroperitoneum. So a lot of the steps of operations are embedded in this operation. And secondly, the exposure is so good because it is a maximally invasive surgery, and they're able to appreciate the visceral and the vascular anatomy in a very good way. So it really helps them to become better surgeons. And not only that, I always try to do this operation by standing on the left side of the patient and have the resident or the fellow or the trainee on the right side, so that they get the confidence that they're doing this operation independently, although you walk them through this operation, and after a couple of operations, they're able to do them independently. There are a number of ways of doing this operation, but I would say that how we do it, and that's is more in the warm dissection. And I kind of split this operation into 2 parts, the warm dissection part and the cold dissection part. And what I mean by warm dissection is the steps of the operation with the heart beating from incision to cross clamp, which is the warm dissection. And then from cross clamp to removing the organs is in the cold. But when you are doing a DCD procurement, everything is in the cold, and hardly there's anything in the warm. So it's a standardized operation, and I think a lot of programs do it in a very standardized fashion, and that's what I'm going to show today. And I've broken down this operation into 10 parts. One is the warm dissection, which is you start from the midline incision. You basically then divide the sternum. I think it's very important to divide the sternum because and learn how to divide the sternum, because many times it's only the thoracic team and the cardiac teams that divide the sternum. But I would say it's good for all the surgeons who are going to do multi-organ procurement learn how to do the step of this operation. And because it gives great exposure of the heart, and you can, if you can't cross clamp the supraceliac aorta, you can cross clamp the aorta in the chest, and then you can also vent out all the flush in the chest cavity. And the rest of the steps, you are mobilizing the colon, then you rotate the viscera medially to expose the SMA, the aorta and the IVC. Then you isolate the IMV for the portal flush, then isolate the infrarenal aorta for the aortic flush, and then expose the supraceliac aorta for the higher dissection if you're doing only abdominal retrieval of liver, kidneys, and pancreas. And if you have in the chest, you can cross clamp in the chest. Then you expose, incise the gallbladder, flush it, get rid of all the bile, cannulate the IMV next, and then cannulate the infrarenal aorta for the aortic flush. And these are the 10 steps. If you do it and you learn these 10 steps, it's much easier, and it becomes a very standardized operation. And then you do the, you give heparin 30,000 units and start cross clamp, and then do the cold dissection. And the cold dissection I kind of divide in 5 steps. First is dissection of the porta hepatis, which would be dissection of the common hepatic duct, bile duct, and portal vein. Then division of the infrahepatic IVC above the renal vein, division of the suprahepatic IVC, and then you remove the liver first, then the pancreas is removed with the spleen, and finally the 2 kidneys are removed en bloc, and the final back table separation of the kidneys is done on the back table. This video is, I'm going to demonstrate the steps that I just went through, and I'll walk you through these steps. And this video is part of the training curriculum, and it's on the ASTS website. It was designed and made by Dr. Humar, and this is a very standard video that we use for training our resident and fellows for this operation. So I'm going to start the video now. So you, as I said, start with a big midline incision extending from the xiphoid or the sternal notch and going down to the pubic symphysis. You can see the sternum is being retracted, and you're incising the pericardium to expose the heart. Once you've exposed the heart and you've put the retractors, abdominal retractors, you start with division of the falciform ligament, and then do the Kirtle-Brash maneuver to mobilize the right colon, and do the cochlearization of the duodenum to expose the aorta and IVC. And here you can see the lateral attachments of the colon are being reflected. It's being extended up to the hepatic flexure. The colon is being freed, the right colon. You get up to the transverse colon. And then you rotate the small bowel medially to expose the SMA above the left renal vein. Here you're exposing the SMA. You have cochlearized the duodenum already. And here you can see the IVC and the left renal vein crossing, and the SMA is being freed up just above the left renal vein. Here you can see the dissection and isolation of the SMA, and a vessel loop is passed around it. And then the next is isolation of the IMV. This is will be used for the portal flush. And next, the IMA is identified, and the infrarenal aorta is being dissected out. Here do you see the ligatures, silk ties are passed around the IMA. It's ligated and then divided. And here the infrarenal aorta is being mobilized, and umbilical tape is passed around as distally. And then and one umbilical tape is passed proximally. And next, you start with the division of the gastrohepatic omentum and trace the accessory left hepatic artery. And if it is there, you should always secure it. You divide the crust of the diaphragm to expose the supraceliac aorta. You get around the supraceliac aorta and ready for cross clamping it there. And then you start some part of the hilar dissection, as I said, is still in the worm. You identify the common hepatic artery at the hilum, and then trace it proximally. And the cystic lymph node is kind of your landmark to trace it more proximally, and then you identify the GDA. The same thing, you ligate between two silk ties and then divide. And then you move more proximally towards the splenic artery, isolate it. You pass a vessel loop around it, and this helps to preventing the overflushing of the pancreas during portal flush. And next, you do the dissection of the common bile duct, pass a tide the common bile duct, incise the gallbladder, flush all the bile from the gallbladder. Once that is done, you're almost ready to flush. You first put a portal cannula in the IMV, make a small venotomy in the IMV, and place a portal cannula. Should not be too much advanced, just up to the splenic vein. And this is then secured, and you start ligating the infrarenal aorta, ready to put a cannula into the aorta. An arteriotomy is made. The aortic cannula is then inserted, and it's secured proximally. The cannula tip shouldn't go above the renal artery, should just stay below. The proximal artery is then secured, and your heparin is given, and the supraceliac aorta is then cross-clamped with an umbilical tape or clamp, and you start the flush and put all the slush around the abdominal organs. And this ends the warm dissection, and the cold dissection part starts. The venting is done. We like to do it in the chest. And then you start the cold dissection by dividing the common bile duct first, and then dividing the portal vein. It's divided in a fashion that you keep adequate length for the liver, as well as leave adequate length with the pancreas. And once that is completed, you go on to the common hepatic artery again. You start freeing it up and move towards the celiac axis. The left accessory is being made sure that it does not get ligated or divided. You get on to more proximity to divide the splenic artery, and then you remove the celiac with a little cuff of the aorta. Here you remove the celiac axis, leaving the SMA for the pancreas. and then the posterior dissection of the liver. The IVC is divided above the left renal veins. And the right lobe is also removed with the rim of diaphragm, and then the suprahepatic IVC is finally divided, and the liver is removed and packaged. And then the pancreas and the kidneys are removed next. The pancreas is being freed from the anterior surface, posterior surface of the stomach, and you basically free up the duodenum and the jejunum, and so that you can remove the pancreas with the root of the mesentery intact. Here, the stomach is being separated out, and then the spleen is used as a handle to free the posterior attachments of the pancreas, make sure the capsule is intact. And finally, the pancreas is removed with the C-loop of the duodenum and the spleen. The kidneys are removed next en bloc by dividing the two ureters and then dividing the IVC and the aorta. And the en bloc removal of the kidneys is then done on the back table, the separation of the kidneys. You posteriorly dissect and divide the aorta. And after you've divided, you leave a cuff of the aorta with the both renal arteries, making sure there are no accessory renal arteries. And then you divide the IVC to separate the two renal veins, and you can remove the fat from the kidney, and it is almost ready to be packaged. In the interest of time, I did not show too many steps of the kidney removal. I'm sure there'll be other speakers who will do that. Thank you very much. That's all I have.
Professor Kashyap, thank you very much for a brief overview of the multiple abdominal organ retrieval. And there are few questions in the chat box from the residents, and they want to know, when you are already opening the thorax, then why not clamp the aorta in thorax by choice?
Absolutely. Whenever we open the thorax, and we always like to cross clamp in the chest rather than the supraceliac, because supraceliac is sometimes in very obese patients, it's very hard to get to it and to expose the supraceliac aorta. So exposure in the clamping in the thoracic of the thoracic aorta is the preferred way.
And you have taken a long cruciate incision, long midline straight incision. Why not take a cruciate incision, which will give you better exposure of all the organs?
Yeah, no, I agree. The cruciate incision, we reserve it because in patients, as I said, who are very kind of obese and are difficult exposure, but there are very some patients who have low BMI. It's very easy to just with a good abdominal wall retractor, you can still get the maximal exposure without a cruciate incision. So we keep the cruciate incision back in our pocket, and if required, it is always done. That I totally agree. That's not we don't do on every donor, but we do on majority of our donors. We do cruciate incisions.
Okay, and what special precautions do you take to avoid injuries to aberrant or accessory renal arteries? Because we haven't done any imaging to that extent in these donors.
Yeah, so that's a very good question, because the outcome of these organs are based on how well you retrieve these organs, and I think it is very important that before somebody independently retrieves these organs, they should go over at least about 20 to 25 donors with somebody who's experienced and can show them how where to find the right accessory artery, where to find the left accessory artery. You know, when you're retrieving the kidneys, make sure the multiple renal arteries are, identified. And so we sometimes split the aorta rather than en bloc removing the kidneys. We do in situ splitting of the aorta and anteriorly, and explore and see how many arteries are on each side for the kidneys. And that is, I think it's experience. It takes time to make sure. But if having a good exposure will help that, and as you said, a cruciate incision or a good exposure of the chest and everything will reduce the number of errors of causing any injury to accessory artery.
Right, sir. Dr. Jamal wants to ask a question. Dr. Jamal, please.
Yeah, very nice video, Professor Kashyap. I have a question. You have described the division of the GDA in the warm phase. Do you think there would be something to be said for not dividing any arterial structure in the warm phase? Because anomalies like replacement of a right hepatic artery by a branch arising from the GDA have been described. And if you did describe it in the warm phase, you would end up not having arterial perfusion of that segment of the liver. So would it not be safer just to not divide any arterial structure and just do all these in the cold phase so that perfusion is assured? Dr. Kashyap, you have to unmute yourself.
Dr. Kashyap, unmute yourself, please. Dr. Kashyap, unmute.
Yeah, I'm sorry for that. Yeah, no, I appreciate that. I think you're absolutely right. There's so many anomalies that sometimes you see that the accessory may be arising from the GDA or from the SMA or from the left gastric, and you're right. It's better to preserve till the end, and that's a step which I showed is to. Did I lose anyone of you or no? Okay, sorry. So that's I agree. I think that's it's as we don't divide the splenic, and I'm absolutely fine if we don't divide the GDA also until the cold time. So that's clearly I agree with you.
Okay, Professor Kashyap, Professor Kashyap, there is a question from audience. Why add flushing of inferior mesenteric vein also? Is aortic flush not enough?
Yeah, because for livers, and we definitely like a portal flush. And that's for if it was a kidney retrieval alone, I'm absolutely fine. There's no need for a portal flush in those cases. But when we are procuring the liver and the pancreas, and because sometimes it's the liver team that procures the pancreas, or the pancreas team procures the liver or the kidney. So it's kind of based on what organs we are retrieving, we decide whether to do the portal flush. And many times for the livers also, we don't do if the cannulation is difficult or something didn't go right during the flushing the IMV, we do it on the back table, the flushing of the portal vein. So you're right, that step is not has to be done in every
case. Professor Shroff is here, Dr. Sunil Shroff. May I ask you a question, sir?
Sir, it's a pleasure and honor to be in this esteemed faculty, and I really appreciate. Please answer anything I can help.
Professor Shroff, what do you prefer, en bloc retrieval versus in situ separation of kidneys? What is your choice and why?
Good evening to everyone. First of all, apologies for being late. I was in another webinar, and it's great to see Dr. Kashyap, I think Rochester, and Tohed and Arun, and so many of you friends after a very long time. So in situ or en bloc, see, as you get experience, en bloc is always going to be better. But initially, when you are gaining experience, I would always recommend that you separate, as Dr. Kashyap said, you can divide the aorta, see the aberrant vessels, and then take it. I mean, how many vessels are there besides separate vessels, and then take it like that, because it's much easier to do that. Just like you do a normal nephrectomy. At least when you're starting off new, you don't have a mentor. If you have a mentor, and if you're done about 15 to 20 under a mentor, then you're absolutely okay. But when you're starting new, I would say that you do it on the table. You divide the vessels, and go, even if you go a little slow, it won't matter. Remember that in India, our donors are very young donors. They do take a little bit more insult than perhaps a marginal donor or an extended criteria donor, which you get in West. So I would do, as a beginner, I would just take it easy and do it on the table. I'll separate the kidneys and then take it out. That's my experience, and that's what I teach my students as well to do.
Thank you very much. Professor Vatsala Trivedi.
I just want to add one more point to this. To
Yes,
avoid vessel injury and to avoid, aberrant, even, you could have another ureter also, you must make sure that from adrenal down to the golden triangle, to the ureter, all the fat around the kidney is preserved as is. Don't disturb any area around the hilum or anything. Just take the kidney as whole with as much fat as possible around it, with the adrenal and lower down, and then do it on your bench. All your requirement, then you will not die any of these things, believe me.
Okay, sir. Thank you very much for those words of wisdom. Professor Vatsala Trivedi, madam, you need to answer these questions for our residents. Please highlight the importance of retrieving or harvesting a set of iliac vessels for each organ, say kidney and liver, both. Please.
I have been doing this from the beginning because most of the time when I received the kidney, there were some problems that you have to do the extension graft or you require. And apart from that, I thought wherever we send the kidney, suppose they have some mishap, they can utilize the iliac arteries I sent along with that. And once only I had to do the saphenous vein extension when I received kidney from somewhere. This is all precaution because I did from 1997 where everything was a primitive. So I never wanted to take the chance and waste time. That's why I have always taken the iliac vessels and with every transplant, every kidney, I have sent the iliac vessels to somebody. I mean, whoever I have sent.
Thank you very much, madam. Professor Pranjal Modi, are you there? Just one quick question to you, sir. Dr. Pranjal Modi?
Yes, I'm here.
Sir, for the benefit of residents, please answer this question. When you take a decision to retrieve deceased donor organs, is there any minimum basic pre-retrieval abdominal imaging which you would insist upon?
Yes, the minimum requirement is ultrasound. However, especially for liver, sometimes it is not adequate. If CT is available, plain CT also, it is good enough because we would like to identify some of the pathology, especially fatty liver, right? It is for the liver purpose. For kidney, if incidental tumor is there, it can be identified both in ultrasound as well as in CT images. However, often the CT images are not available. It's not must, but if it is available, we would certainly prefer. Nowadays in COVID time, the CT thorax is also must, especially for the lung and heart retrieval. Lung retrieval, they ask for the CT thorax. So it's a guideline by the NOTO also that you have to do the CT thorax before procurement of the organ, and you have to have a COVID negative test by RT-PCR assay, especially during this time. So these are the basic imaging required. Minimum ultrasound, otherwise preferably CT.
Thank you very much, sir. So there are a lot of questions, but for want of time, I move on to the next agenda, that is multiple abdominal organ retrieval by Dr. Anurag Shrimal. He is the multiple abdominal organ transplant surgeon at Global Hospital Parel, Mumbai. He has been basically trained in India and has done organ transplant fellowship from USA. With brief introduction, I hand over the proceedings to Dr. Anurag Shrimal. Most welcome. Please proceed. Anurag, unmute yourself. Anurag.
Yeah, thank you, Dr. Oswal, and to all the seniors around. I'll start sharing my screen.
Optimize for video, Anurag.
Yes, just give me a second.
Make it full screen, please.
Yeah. Is my screen seen now?
Yes. Please proceed. Please proceed.
So it's just like I've taken a record of this. Some of the instruments the donor vitals at the time. I put in the cautery very high at the time of abdominal incision. So the first of it is the midline abdominal incision. And as discussed previously, we go ahead with a um, with a cruciate, followed by sternotomy, ligation, quality assessment for the liver. That's a very, very important step because a visual inspection of the liver can give a very good idea. At the same time, assessment of the abdominal viscera, as we discussed that sometimes the imaging is not available. So it's important to rule out any form of a disease, especially any malignancy of the abdominal viscera before proceeding with organ retrieval. So as you saw in the previous videos, the cattle brush maneuver or an extended cattle brush maneuver. Now dissecting the duodenum off. And at this point of time, it'll dissect the completely the renal, the IVC and the renal vein. So I make a point to define the junction of the IVC with the left renal vein, and that will help us identify it. As discussed in the previous video, dissection of the SMA. This is especially helpful to locate any replaced right hepatic artery. Followed by that, dissection of the abdominal aorta and ligation of the inferior mesenteric artery. The lumbars are sometimes very close, so be careful, especially for the residents when they start the first view. Followed by that, the dissection of the inferior mesenteric vein. I had included it for the purpose of this video, but now most of the times we actually use only aortic flush. Division of the left triangular ligament. And that was the location, if at all, if there is an accessory left hepatic artery, that would be the location. So always look for it, feel for it as described in the previous video. So in this case, there was no accessory left. Then we go on. Now this is a step which I prefer to do it differently. And what I prefer is a circumferential dissection of the portal vein in the warm phase. And that's very, very important, especially to prevent any injury to an accessory right artery, because if that's there, it can be defined and it could be very well seen. So we dissected and we now ligated the right gastric artery, working on the other side of the porta now. So, and then that's the looping of the bile duct, and the bile duct is divided at this stage and the bile is flushed out. This is again a step which is especially important for the residents or the newcomers to aspirate the bile before they go ahead and divide it. In our unit, our preference is to do more of the warm dissection. So that's the junction of the splenic vessels with the hepatic artery, and there is always a thick layer of tissue. So again, for identification in the cold, we kind of mark it with a loop. Now, sometimes, especially if there is a concomitant pancreas procurement as well, identification of the uh, of a vessel going to the pancreas could be very important here. So, and that's the dissection for the suprahepatic, the supraceliac abdominal aorta. That's also looped and kept ready for a cross clamp. So some now with what is happening that with most of the organ procurements there is a concomitant procurement of the thoracic organs, and in that situation it's not possible to have an access to the to the thoracic abdominal aorta. We also loop the IVC and ligate it during the cold phase. I prefer to divide the bile duct towards the end of the warm dissection, and because there's always some trickling of the blood that would kind of make the field a little bit messy. That's flushing of the gallbladder in the CBD, and now we are preparing for the abdominal cannulation. So the the distal aorta is ligated. The abdominal aorta is cannulated. The supraceliac abdominal aorta is now cross clamped, and the it's vented out in the chest. There was no cardiac procurement, and the abdominal cavity is. So I prefer to ligate the distal IVC as well to prevent the venous return from the lower extremities. Now we have started the liver retrieval. So that's the division of the now working on the portal vein, and when there is no pancreas retrieval, we prefer to use the Y of the SMA and the SMV and the splenic vein to ensure a good length of the portal vein. And as discussed in the previous video of the abdominal aorta, so that's a. And now dividing the rest of the attachments of the liver. Now division of the IVC. So as we had looped and marked the position, and then the entire liver comes out. So as we discussed even in the previous video, I prefer, or our unit's preference is back table flush of the liver. So I'll just transition over to the kidney video. Give me a second. Yeah. Is this visible? Is the kidney video visible?
Yes, Anurag.
So in the warm phase, I would just add one step that I prefer to dissect the ureters bilaterally in the warm phase. So at the beginning of the dissection only, as you can see that the lateral incision is lateral to the gonadal vessel complex, and then I loop the ureter with the entire periureteric tissue on the surface of the vessel, on the surface of the iliac vessels, so that Though it's very, very rare that there may be more than one ureter, duplication of ureter, but in that case, even in any form of ureter, there will be no injury to the ureter, as well as the perivascular sheet is prepared, periureteric sheet is prepared. The same looping of the ureter on the other side now, on the left side. Now, this is the cold phase dissection for the kidneys. So the first, the ureter being divided. Identified and just clipped so as to have a good retraction of the ureter. The left ureter now getting dissected and divided. And again, the gonadal vessel is preserved with the ureter. Now the ureter dissected up to the sigmoid, from the sigmoid colon. The left colon is mobilized off the left kidney. The plane of dissection is important because sometimes, especially in the first few procurements, the surgeon may tend to go into the Girota's fascia. So it's important to avoid that. And you can see the Girotas getting reflected down and the colon and the mesocolon getting reflected up. And and at this point of time, I open the mesocolon as well. The posterior dissection from the retroperitoneum, where the entire the peri and the pararenal fat is taken along with the kidney up. Kidney now getting dissected off the spleen. And the ureter is now flipped through the mesentery of the colon. So both the right and the left sided ureters have been divided. Now working at the vessels, so dividing the abdominal aorta or the infrarenal aorta and the IVC. So this is work on the other side, the right kidney, which is again reflected from the retroperitoneum completely. I prefer that the kidney should be reflected right up to the paraspinal muscles where the tendons are seen well, and then start the anterior dissection. So both the ureters have been retracted superiorly. The abdominal aorta getting divided. and the IVC is divided at this stage. Now, this is one of the safest techniques that I feel, wherein uh, as we discussed even in the previous presentation, that in the earlier training, the surgeons can prefer to do one of these methods, which is the oblong retrieval. So both the ureters are reflected up and the vessels are reflected up. And finally, the kidneys would be separated from the posterior attachments or from the retroperitoneum. And the plane of dissection should strictly be on the tendons, like the paravertebral muscles. The shiny tendons should be seen well. So they are dissected up to the level of the SMA, which has been dissected previously. And finally, with both the kidneys now reflected down, and you can see the level of the SMA, and then this superior tissue getting divided, the abdominal aorta divided at the level of the SMA, and that completes the oblong retrieval. Now here again, as you saw in the previous video, I prefer an anterior approach for the separation of the two kidneys. So the first, the left renal vein is identified. The left renal vein is identified and divided from the IVC with just a cuff of the IVC. The entire IVC is left with the right vein in case the right vein, the surgeons prefer to lengthen the renal vein using the IVC, and just reflect it a little bit more to make sure that it is reflected off the abdominal aorta. Now abdominal aorta anteriorly getting divided. In the midline, you can see the IMA stump. So right in the midline, and the superiorly, the origin of the SMA would define the midline. So right and the left renal arteries well seen, along with a good patch of the abdominal aorta, and then a division of the posterior abdominal aorta. The landmark would be the lumbar vessels origin. So to work between the two lumbar, definitely be in the center of the abdominal aorta, and that completes the separation of the right and the left kidney. The left kidney, the vessel seen well. And with this technique, we ensure that there is no dissection done in the golden triangle. The kidneys can then be subsequently flushed again on the back table and packed for, after defatting, can be packed for transportation. As I mentioned, you can see the right kidney with the IVC, and it can be used to lengthen the right renal vein if needed. I'll stop sharing my screen now.
Thank you, Anurag, for a wonderful demonstration of abdominal organ retrieval. Your video quality was excellent, and bandwidth today has been kind to all of us. So there are few quick questions from the audience. Foremost, Dr. Pranjal Modi had raised two questions. What is your experience for fusion anomalies of the kidney during procurement, and what are the precautions you take to avoid complications in that situation?
Yeah, so I have faced this situation only once, where we had a horseshoe-shaped kidney. We could identify it during the abdominal dissection, and we retrieved it oblong to avoid any injury. And that's been my only experience. That was a one-time experience.
Okay, and another question from Professor Modi is, what are the tips to identify retroaortic or circumaortic left renal vein?
Yeah, that's a very, very important question. So especially when we are doing the dissection of the IVC, as I mentioned that I prefer to define the left renal vein and the IVC junction. So if we don't find the left renal vein IVC junction, or if we at times find that the diameter of the left renal vein is very, very small, that would be an indicator that that there may be a retroaortic left renal vein.
Okay. Now I request Dr. Pranjal Modi to answer those same questions because he is the teacher and we are the students. Dr. Pranjal Modi.
No, no, it's not like that. Just even I have only one experience of a fusion anomaly, not much. But yes, one has to be very careful when it is being doubted pre-operative if you know already about it. So especially by the investigations. So then you have to be very careful because the fusion anomaly kidney are unascended kidney and large, and there is an inferior mesenteric artery which is restricting the upward migration, especially in a horseshoe kidney. So very carefully you have to identify the inferior mesenteric artery and divide it, and at that time isthmus injury should be avoided. And your perfusion level it will be very, very low, like means you have to do with the into the common iliac artery. Perfusion through the common iliac artery is preferred rather than over the aorta, because there will be many aortic arteries are going to the isthmus or to the renal parenchyma, which could be bilateral. So then, and the rest of the thing is en bloc dissection. If, however, the fusion anomaly is in the pelvic region, or maybe unascended kidney in the pelvic region and fusion anomaly, which is very complex situation. In that case, you have to go further down, maybe with the external iliac artery, and just advance the tip of the cannula into the common iliac artery, ligate close to the, or the fix the cannula close to the bifurcation of the common iliac artery to the internal and external. At that level, you ligate it, and opposite side common iliac artery also can be ligated distally only. So in that case, the arterial blood supply to the pelvic kidney is often from both the vessels, both side, and that can be preserved also. And so is the case of a vena cava. Entire vena cava is to be preserved with the kidney. So I think these are very important tips, especially the vascular injury during the fusion anomaly can be prevented. And then the rest of the job is by the recipient surgeon, whether he wants to separate out, especially in case of horseshoe kidney, or they do the en bloc transplant. That is the choice of the surgeon. Thank you.
Thank you, sir. So, Dr. Anurag, while inserting the aortic cannula, you have to be extremely careful not to overshoot beyond the point of renal artery. So, how do you ensure that?
So multiple ways. One, that some of the cannulas comes with a bulb, which can be palpated very well. The length of the cannula that we insert, and the origin of the IMA is a very good guide that do not push it beyond that. It's very important point that you raised.
Okay. And the method of dealing with the ureter in warm phase is I am seeing for the first time. Usually, most of the surgeons deal with the ureter in cold phase. Why you have dealt with them bilaterally in warm phase only?
I mean, as there have been many techniques, and everybody would be comfortable with one or the other, I would say. I personally feel that, especially the younger surgeons, like I'm trained in US, and the tradition is that the first thing you start learning in transplant is organ procurement. So the younger surgeons are sent, and cold dissection is a skill that is acquired over a period of time, as compared to the warm dissection, which all of us as surgeons know it. So I feel that identification of the uretrogonadal complex is very easy in the warm phase, and if they are looped, it becomes very easy, avoiding any injury to the ureter or any injury to the iliac vessels, especially for the young surgeons. For experienced surgeons, I think it doesn't matter.
And Ajay, I would say that even I do it in warm phase. I don't do it in cold phase. I find it so much easier to do it in warm phase.
Yes, sir. Yes, sir. Then Anurag, Most of the surgeons would put the kidneys upside down and dissect cut the aorta posteriorly first when they have retrieved en bloc. You have done the exactly opposite. Why so?
Uh, Again, I would say different methods, different methods, and the way I'm more comfortable. I feel that anteriorly I can visualize the junction of the left renal vein and the IVC very well. And again, the midline of the abdominal aorta anteriorly is very well defined with the inferior mesenteric artery and the superior mesenteric artery. And probably that has been how I've learned it. Are the three reasons I would suggest.
Right. Professor Vatsala Trivedi, a small question for you. Trivedi madam, Vatsala madam.
Yes.
There is constant struggle for IVC length between liver surgeons and kidney surgeons. So where do you draw the line? I have interacted with so many liver surgeons. They always keep on fighting, and sometimes they take a piece of right renal vein, and then we'll end up in deep trouble.
If you are in the theater, you guard your renal vein left as well as right, and ask them to cut just above that, not allow the right renal vein to go. And as everybody has said, you have to take the IVC along with the right renal vein. And left is always a longer vein you can do without having the IVC. Liver people do fight all right, but they are quite friendly. They allow us to take one.
Okay, madam. And what
In
is
fact,
your...
today, in fact,
Sorry.
I would appreciate liver surgeons today. Most of the dissections they do, once upon a time, going only for the kidney was much bloodier than what today the organ retrieval is happening.
Okay,
so I'm
thank
very.
you. What is your personal preference, en bloc retrieval or in situ separation, and why?
No, I have unblock. Always I have taken unblock, and as you said, I put backside front and cut the aorta from the backside between the two lumbar. There are always lumbar vessels, so you can always go in the midline. You can visualize both the renal vessels and then pick up the anterior wall, and you can see the junction of the left renal vein and the right renal vein. I have always gone from behind. I have never cut from front.
Professor Shroff.
Yes.
If the donor deteriorates suddenly on table, what should you do? You are in the midst.
Say that again. What did you say?
You are in the midst of abdominal organ retrieval and donor suddenly lands up in cardiac arrest. What would you do?
So, you just go ahead and, you open the abdomen, make sure your kidneys are cold. I'm only concerned of the kidneys. I'm not worried about the liver. Because if you get the kidneys, at least there are two patients will benefit, So in that situation, the first objective is to make sure your kidneys are nice and cold. So put a lot of ice around, dissect posteriorly, put a lot of ice around the kidney, make sure it is all, nicely kept cold. And then do a en bloc quick retrieval as fast as possible, and then work on your bench. It'll be easiest thing to do. It requires a little bit of quickness, requires a little bit of experience, but in that situation, I think that is the best option. Do a en bloc quick dissection and get them on table, but keep your kidneys cold. That is the important thing. But if you've got your cannulas inside, let's say, in that situation, then you can again you can also do perfusion if you want. All you have to do is vent out the vessels, tie as you normally do. If you can get a control of the suprarenal part of the aorta, and and you can open the chest and vent out the vena cava, then you can do perfusion if you can. It all depends where in what situation the arrest has happened. But if the arrest has happened, obviously you're talking about a warm phase arrest. Then in that situation, yes, if the dissections have not been carried out quite a lot, in that situation, first objective is to get your kidneys out. And for that, you need to make sure the kidney don't get warm. So keep them cold, nicely cold. That's what
Thank you, sir. So now,
Dr. Can I add?
Please.
Yeah, Dr. Oswal, so I means whenever I start a procurement, I request our anesthetist three things. That is very important. That first is that give good relaxation to the donor, because even though they are brain dead, they need good relaxation. The second is that keep 30,000 units of heparin loaded with you. In case the liver becomes unstable, we don't have to search for it. And the third is please inform if there is any instability so that we can do a very quick cross clamp and all organs could be salvaged.
Right. Okay. Over to you, Dr. Kunal Yadav. Without wasting much of time, please start your presentation. Dr. Kunal Yadav is at University of Toledo, Ohio, USA. Please.
Yes. Thank you for giving me the opportunity to present a video. I'm a transplant surgeon at University of Toledo, and I send greetings from here and also on behalf of Dr. Sindhwani, who unfortunately could not make it to the meeting. He's in a flight right now, so but he sends his regards. So quick brief about University of Toledo before I start this. We are located in Northwest Ohio. We do about 100 to 150 kidney transplants a year. And we've been doing transplants for about 40 years here. And majority of our transplants these days have been deceased donors because our waiting time is one of the shortest in the country. And we also have Matt Wadsworth here, who we work with very closely. He's a CEO of Life Connection, who will be talking later on. So he's been our OPO CEO, and we have one of the best performing OPOs in the country right now. So without further ado, let me share my screen and talk you through my video. All right. So this is a pre-recorded video. So if you can't hear me, let me know that, and then I can just sort of start talking. Okay, so this is a DCD donor that we are going to do kidney donation from. And so we're not using any bovine cautery. We're just going to use knife and scissors, make a long midline incision, initially in the abdomen, later on in the chest also. So after making that incision, we put a big valve retractor inside and then lift the small bowel and the large bowel up and do a quick Retrieval brush maneuver. Just go down to the intrarenal aorta. Now we can see the iliacs here. We'll try to encircle the intrarenal aorta and put a clamp at the distal end. That's right there. And then we cut the aorta on top of that and cannula. This patient, I use French aortic cannula, like 20 to 24 French, depending on how you want to. We secure this of umbilical tape. You can also use a big number 5 ethicon. That also works pretty well. The aorta was quite crunchy.
Yes, capsule ಮಾಡಕ್ಕೆ ಹೋಗೋದಿದೆ exam. Oh, yeah, history ಹೇಳಿದ್ನಲ್ಲ.
On the left side there was lesions that I'm going to remove.
ನೀವು ಎಲ್ಲಿದ್ದೀರಿ ಹೇಳಕ್ಕೆ? ಅವ್ರಿದ್ರಿ ಇನ್ನೊಬ್ರು. ಅವ್ರಿಗೆ ಹೇಳ್ಬಿಟ್ಟು ಹೋಗಿ ಅವ್ರ ಮರುಜ.
Someone's video.
Last allow ಮಾಡ್ತೀನಿ.
Someone's video is disturbing us. Someone's video is disturbing us, please.
Now we're using the left pleura. I'm trying to locate the descending aorta in this case. In DCD donors, I like to clamp the supraceliac aorta in the chest instead of in the abdomen. I feel that's easier to do, and I can do that much more quickly. And I'm sure for that I'm clamping the aorta in this case. And then we open the pericardium, and then we're going to make an incision into the IVC and drain all the blood out. So this is the portion which needs to be done pretty quickly. I try to cannulate the aorta within 2 to 3 minutes of making the incision, and all the remaining steps are also done pretty quickly until this point. And after this, when you have organs all flushed and everything, then we can take more time. While the flush is going on, I usually try to put around 5 liters of aorta in these and lift those out. And then once the flush is complete, then I usually divide the diaphragm. And I like to take the liver out in these cases, even if we're just procuring the kidney because it creates more space and it makes it easier to do the kidney retrieval. Now we're dividing the diaphragm here, and I will take all the ice out around the kidneys, and then we'll dissect above the liver. Need to be careful about the esophagus at that point. Now I'm dissecting in the porta hepatis. I'm seeing the bile duct, a pretty big bile duct in this patient because it doesn't have a gallbladder. And by the portal vein, and then you have the hepatic artery. If it's a liver procurement also, I would go all the way down to the celiac, but in this case, if we're not procuring the liver for transplant, I divided it at the level of the common hepatic artery. After that is done, then we start dissecting below the liver. And now we're doing the complete Catal-Brash maneuver because, as you remember earlier, we didn't do a full Catal-Brash maneuver in this case. So we're just finishing that and into a cooker and exposing the IVC. Now here on this picture, you can see the IVC, you can see the right renal vein coming off, and you can see some prongs of an IVC filter, which we saw in this case. After this, we go right on top of the IVC, and I try to cheat on the side of the liver in this case because we are procuring the liver for transplant, like we said earlier. So we will try to give the kidney team as much cava as we can. So we divide the cava. There was a central veins catheter in place, which we took out. And then the remaining attachments of the liver will then be divided, the remaining diaphragmatic attachments. And you put a finger inside the cava behind the liver and then pull the liver up and divide all the remaining attachments, and the liver is free and removed. It flushed fairly well in this case. Then we remove the aortic cannula and the clamp in the distal aorta. The next step, I divide the IVC next to the aorta, next to where already the aorta. We divide the IVC at the same place. Catheter, and we see a little bit of clot coming out of the IVC, which is always the case. So we remove that. After that, I look for the ureter. I usually put my finger below the ureter and then feel the ureter with my thumb and index finger. And then I get some tissue around the ureter and also the portion of the gonadal vein also. Make sure you maintain vascularity to the ureter. And we go to the point where the ureter crosses the iliac artery and divide the ureter down there. So that we give a good length of the ureter. And see the stellate cross section of the ureter. And then we'll put a hemostat on that ureter and then reflect it immediately. And then you divide the attachment of the kidney perpendicular to the psoas. Similarly, now we are identifying the left ureter. We have reflected the descending and sigmoid colon medially to be able to identify that. And once again, we identify that, sort of put the finger around it and go down to the iliac and divide it. Now we have a side of that. Then we start dividing the attachments of the kidney, kidney to the diaphragm, kidney to the spleen, and the pancreas. So I find it easy to do some finger dissection, to just sort of bluntly dissect this area, and then do a mixture of that and sharp dissection with the scissors. And here we have the pancreas, and we're dissecting the attachments between the kidney and the pancreas right here. And again, you see a cyst in that kidney. And then now we've reflected the descending and sigmoid colon laterally and brought the kidney medially so that both the kidneys lie next to each other. Now, I try to divide the kidneys on the front table itself and not take them out and block and divide them on the back table because I feel this is easier to do. And this is something I would recommend because you have the OR lights on, you already have the kidneys in an anatomical position. So I always feel that this is an easier way to do it. Then after you divide the left renal vein, you dissect right on top of the aorta. And we'll keep going up. And
Unal, your video is not running properly. If you don't mind, can we proceed to question and answers?
Are you not able to view it at all, or what's going on with the
No,
video?
not at all. Not at all.
Very, very jumpy.
Okay, that's unfortunate. Okay, has it been that way from the beginning, or you just started feeling it jumpy? And
from the beginning, I thought we would improve, but it hasn't. So my suggestion to you is we'll straight away ask tips from you.
okay, all right. So I
Okay.
can start.
In a deceased donor, in a DCT donor, why in kidney retrieval only? Why did you remove the liver?
I always remove it just because it creates more space for the kidneys, and then sort of when I'm dissecting the kidneys around, it sort of I have more space around. So because of that, biopsies, just because they can have intraparenchymal thrombi sometimes, and we just want to make sure that they don't have that.
And do you do a true cut needle biopsy, or you take a piece by using a 15-number plate?
We usually take a wedge biopsy because we also want to close it. There are some places which do a core biopsy, which sometimes is better because you might have some fibrosis right under the capsule in cases of wedge biopsy. But the problem is that it's difficult to close, and then if the kidneys are coming from outside, we don't really know where they punctured the kidney. And then only after reperfusion, we're able to see the bleeding from there, and then we need to fix it. So I usually try to do wet biopsy and then close it before sending the kidney out.
Okay. Any medical legal implications for such liver removal when the liver is not going to be used for transplant and still you are removing the liver? Are there any medical legal hazards of doing that?
There are not. I mean, we put the liver back in at the end of the procurement. So before we close the patient, we put, except for the kidneys, everything else is going to go into the patient, including the fat around the kidneys and everything. Before we close the patient, everything is inside the patient.
Okay. Then if in DCD donor, if the aorta is calcified and like a pipe stem, how do you clamp or how do you cannulate and how do you ligate?
So this one, in fact, was very, very calcified. So we had that difficulty. So usually you're still able to find the. So you just need to make sure that you're going into the true lumen. Occasionally, in case you absolutely cannot put a cannula in the infrarenal aorta, that is supraceliac, and so put it the cannula in the axis itself, or you can put it in the supraceliac aorta. But that's very rare. I mean, almost never been a case that I've not been able to cannulate the infrarenal aorta.
Okay. And in DCT donor, when do you give heparin?
DCT donors, they usually about 5 minutes before withdrawal of care, we try to give heparin so that it has enough time to circulate in the body system before withdrawing care. Because if we withdraw care and the patient crashes right then you don't have enough time for the heparin to circulate in the system. Sometimes in addition, what we might do is to also put heparin in the flush. So we give the 30,000 units of heparin before withdrawal of care, and also when we are flushing the organs. In the flush solution itself, we're going to put some of that heparin in the flush solution also.
Okay. Have you any experience with double balloon catheter for DCT donors?
Double balloon catheter. What is that for?
Double balloon catheter for DCT donors.
I've not heard about that.
That will only apply for kidneys. What he's asking is only perfusion of the kidneys, for the double balloon catheters. If I understand the question right.
Yes, Professor Shroff, you have hit the nail on the head.
Only doing kidney retrieval, then double balloon may be useful if you want to do in situ perfusion. But I just want to very quickly mention in a medical legal situation in India, if you're doing that, you must mention that because the case will go for post-mortem, and you must mention your operation notes so that the forensic guy knows about it. I had a situation where the spleen was removed and some notes were removed, and the kidneys were removed in a very early situation, and the forensic guy wrote that the spleen missing, from his commentary. So you must mention all this and make sure that it goes to your forensic guy, because he's the one who's going to do postmortem and record everything what has been happening. So do remember that. And if you are taking a liver out, when you are asked for a kidney retrieval, then make sure the consent itself mentions that the liver is also going to be removed, So in India, you just have to be careful with the medical legal things. Thank you.
Okay, thank you very much. We straight away proceed. Vikas, you want to ask something?
No, Dr. Ajay, can I answer for the double balloon aortic cannulation? Someone asked a question.
Please, a quick comment. Please, quick comment.
Basically, that's been, I've used a double balloon aortic cannulation. That was back in 2012 in UK, where we were doing a trial on uncontrolled DCD with in situ cold perfusion. So that was a start of that era, and subsequently, I think we I mean, the Spanish group did it, and then we did it in the UK. As Dr. Shroff mentioned, it's predominantly for kidney-only retrieval in an uncontrolled DCD. I think we are not looking at that in India.
Okay, right. Now we straight away go to Dr. Jamal. Dr. Jamal does not need any introduction to anyone, so please proceed, Jamal.
Yeah, thank you, Ajay. Am I audible?
Yes.
All right. So I'm sharing my screen. Can you see my slide?
Yes.
Okay, right. So I've been charged to talk on packaging, transport, and bench surgery. I'm going to mostly talk about bench surgery, though, because packaging and transport, there's not a lot to be said to this audience. So grossly, there are three types of storage. Static cold storage is what is predominantly done, especially in our country where machine perfusion has not come yet, but it's on its way. Now, so I'm just going to talk just the very bare bones of a static cold perfusion. The way we do it, and I've got some illustrations for this, the organs are in a sterile bag with cold perfusion fluid, usually 2 liters for the liver, 1 liter or half a liter for the kidneys, and maybe 1 liter for the pancreas. The second and third sterile bags surrounding this just to maintain sterility. And they should be placed in an ice box surrounded by ice, but it's important not to pack them on all sides with ice. So this just shows an organ with grafts inside a bag with solution. Second and third bag surrounding this, but this is very important, no ice inside. I'm only showing this because this used to be done in the past, but it's you're likely to end up with frozen organs here, which could result in these organs being lost. And again, when you pack them, you should any kind of ice box will do, but make sure you don't put ice on top of them. Otherwise, over 6 or 8 hours, you're likely to have frozen fluid inside. Again, transport. This is we travel to a lot of smaller centers and we carry all our own equipment for retrieval, perfusing, and packing. This is just an early archival picture from our early days of traveling by road for retrieval, and the organs used to come back with us by car. Recently, as NATO and the regional and state organizations have got more coordinated, the police have begun to give green corridors, and this can significantly reduce the transit time by road within urban areas. Sorry. And heart and lung teams commonly use aircraft, and we've used them on a few occasions, but it's fairly expensive. So again, most organs are transported by road unless they're interstate. So now coming to bench surgery. What are the aims of benching a kidney? The first is to remove perinephric fat, although some centers do like to transplant with the perinephric fat. There's fibrolymphatic tissue, ganglion tissue, which has to be removed from the hilum. You want to control the hilar lymphatics because they're a potential source of a lymphatic collection post-operatively. You want to inspect the vessels in the ureters and make sure that there's no retrieval injury. Also looking for any other anomalies or pathologies, such as small tumors. You want to ensure that the kidneys are well perfused. So for this, it's good to do a little bit of defatting at the site of retrieval. And for example, if they're suboptimally perfused, you can take care of that then. It may be too late later. And then reconstruction for either multiple vessels or injured vessels, or typically the right renal vein can be done. It's important that in the whole benching procedure, your organ should be submerged in chilled preservative solution throughout. So again, this has already been discussed, but I just have a few slides, so I'll show them. If an en bloc retrieval has been done, so this is typically what you have: 2 kidneys and with the great vessels in between and a lot of ganglion tissue. So after clearing the ganglion tissue, the anatomy is clear, and you can go either from the front or from the back. But if you go from the front, you have to isolate the junction of the left renal vein with the IVC. And once you divide this, your aorta is the only structure joining these 2 organs. And the aorta can be slit from the front. And again, this brings the renal ostia into view, so you know how many vessels you have. And after this, the aorta is slit posteriorly, and the two kidneys are separated. Now I've got two short 4-minute videos showing the benching of the left and the right kidney. So again, unless you believe in transplanting the kidney with a lot of perinephric tissue, the first step is to defat the kidneys. And again, this is to, all this bench surgery should be done using a loop so that you don't cut anything that's not under vision. Any structure, nothing is to be done blindly. And the fat can be removed all the way to the edge of the sinus. So in the left kidney here, we've put the left renal vein on stretch, and we're dissecting it down just to see the length of it. Again, it's critical that you don't divide anything blindly. At this place, there may be a crossing branch of the renal artery, which you have to identify if it's there. You can see all the tributaries of the left renal vein, which have to be controlled and divided. So you can see here, this is the adrenal, the gonadal, and a lumbar, again, which should be seen, positively identified, and then ligated. Right, so this helps you to free up a little more length of the vein and take care of, make sure that you don't miss any bleeders. Any small vessels can also be divided. And also look for any injuries. And in this case, we had an avulsion injury adjacent to the lumbar vein, probably due to traction. After this, the artery, the lymphatics around the artery are divided. And away from the kidney, you can divide the lymphatics without tying them, but close into the hilum, all the columns of lymphatics have to be meticulously divided. Now, the small, possibly a lumbar tributary was divided. After this, we come to separating the adrenal gland from the upper pole. It's important here to not miss a small upper pole twig, which may be arising from the renal artery directly from the aorta. And in this case, there was a small twig which is arising from the aorta, which did not have a connection with the renal artery. So now, as we come to the lymphatics close to the hilum, it's important to break them up into numerous columns and then ligate each column with silk. This is to prevent any. You can see that this accessory artery is not connected to the renal artery, and so we're not going to try and salvage it, because it looks quite small. So the columns of lymphatics are identified and divided, and again, everything that you tie and divide, you do under vision, and typically a loop provides excellent vision for this. So I would say that's mandatory for benching a kidney or for doing transplant. So we're just dividing further lymphatics, and this twig from the aorta is from the upper pole, so we don't have to worry about preserving it. Again, we're separating the gonadal vein from the ureter, but you see that we're maintaining a good amount of periureteric tissue, which is important. And remaining lymphatic tissue around the left renal vein is isolated and tied. So you can see that all the lymphatic tissue has been made into about 5 or 6 columns, and each column has been identified and separately and deliberately ligated. So this minimizes A, any oozing blood on table, and B, lymphatic collections later on. And the final bundle of lymphatics posterior to the artery are tied and divided. And now at this point, you can repair any injuries that have occurred. So this little rent, this avulsion injury adjacent to the lumbar is sutured with proline. And once we do this, we're going to again perfuse the kidney and again look for any other bleeders that may have been missed. So again, just an overview of the hilum. You can see that the artery and vein are quite clean. All unwanted ganglion and fatty tissue has been removed. And you can see 5 or 6 columns of tissue which have been individually ligated. So I don't think hemostasis is a problem. There's one little column of lymphatic tissue which was left untied, and we'll tie it now. And now for hemostasis. So you simply run cold perfusion fluid through the artery and the vein separately, and you just use a piece of gauze to mop the hilum and look for any bleeders. And it's much more comfortable to control these on the bench than later. And similarly, you can clamp the vein, allow it to distend, and rule out any bleeders there. So this is concerning the left kidney. And for the right kidney, most of the benching is fairly similar. Here you have a right kidney with the attached IVC. and all the gyrotous fascia and the perinephric fat over it. Again, it's defatted. And I'm mostly going to focus now on the dissection of the IVC and the right renal vein. So all the connective tissue surrounding the IVC is mobilized to define the IVC and the right renal vein. And I feel, and personally, although many people don't do it, I would like to dissect the right renal vein into the hilum, because sometimes you have avulsion injuries if there's been undue pushing and pulling during the retrieval. Again, it's important to not divide any structure that, only to divide things under vision. And then this dissection can carry on to the fat on the surface of the kidney, so that you've cleared both the hilum and the nearby fat. Again, small tributaries can be identified and divided so that they don't cause. These are small tributaries coming from the adrenal, as you can see. This is a lumbar vein, which is going to be part of our reconstruction, and it's going to be tied off later. Now we turn our attention to the artery. And there's usually one or two small branches arising from the upper edge, and usually these are going to the kidney. So these are divided, and then again, the lymphatics at the back are cut into columns and ligated and divided. And after this, we will turn our attention to reconstructing the right renal vein, so the last of the lymphatics being divided. Okay, it wasn't the last, this is the last one. Right. So now, because the right renal vein is quite short, so we're planning the segment of IVC we're going to use to reconstruct. It's important to remove all this connective tissue from the surface of the IVC to make your suturing better. And now we incise along our planned, along the markings that we planned before. Now it's important here that the tube of IVC that you create should not be narrower than the renal artery. So I like to think of it as a cricket bat, in which this is the handle and this is the blade of the bat, and the blade is significantly wider than the vein. It should not be very wide, but it should certainly not be narrow, because that can predispose to venous thrombosis. And having cut the flaps that you want, again, this is optional, but I prefer to divide them so that you have two free flaps, which you can then approximate with stay sutures, so that the lengths on both sides are both exactly equal. And having a stay suture in each corner sets your vein up very nicely for the reconstruction. And again, there are many ways you can do this, but I prefer to start the suturing at the angle with the renal vein. And using 7-0-proline, run a continuous suture line up both ends, creating your two flaps of the cava into a tube, which is a little wider than your renal vein. And again, though this is not mandatory, we often prefer to run a continuous suture line up about 2/3 of the length of the vein, and then to take interrupted sutures for the last maybe 1.5 or 2 centimeters, which gives us an option of reducing the length of the vein if it's too long for the given recipient. So this is the upper suture line being completed. And then interrupted stitches being taken along the distal, maybe 1.5 or 2 centimeters. And then this allows us to cut this down if we feel the need to on the recipient side. So this completes the reconstruction. And at the end of this, as before, we just do hemostasis, perfuse the artery, clamp the hilum, look for any obvious bleeders. And while perfusing the artery, if you cross clamp the vein, you can achieve a little bit of distension and ensure that there's nothing bleeding, because the right renal vein is often very thin and you have small holes which can leak. Right. So this is something that was discussed in one of the previous presentations. So sometimes, the liver surgeons are cruel to us, and the scissor kind of goes a little lower down onto the vein than we wanted. So this is a situation where the incision on the IVC had impinged onto the origin of the confluence of the right renal vein with the IVC. And we found when we tried to reconstruct it that there was about a 50% narrowing here. Now, this is a difficult situation, but because we have venous tissue available, and ideally we should have iliac vein grafts too, we manage this by putting a patch here to augment this segment that is narrow. So a small piece of cava was used like this just to augment the part that had become narrow. So this is the end of that augmentation. After this, the IVC was reconstructed as usual. This is the upper edge. And this is the on-table appearance where you have the renal vein and the reconstructed IVC and no narrowing at the junction. So I think that's all for benching. And
excellent presentation, Jamal. Let me ask quickly few questions. See, in these both organs, you had excellent lengths of arterial vein both. Then still you made bold cuts and sharp and extensive dissection deep inside the hilum. Are you not afraid of bleeding like I am?
See, there's nothing to be afraid about. I mean, so again, you know, I'm aware that many surgeons don't do such an extensive dissection, but the way I look at it is this, that all the ganglion tissue and fat in the hilum is unwanted tissue. We want the kidney, we want the vessels, and we want the ureter. The two kinds of hilar lymphatics, one are the renal lymphatics, which again, we all admit will need to be ligated. But firstly, there are also periaortic lymphatics that come as part of the retrieval. These actually don't belong to the kidney at all. Probably they don't even have a blood supply by now. So all that tissue needs to come out. Regarding the hilar lymphatics, they all fan out from the hilum. So the closer you go into the hilum, the fewer branches you have to tie. You know, they all come together in a bunch. Whereas if you tie them further away, you have to do many more ties, and you may end up leaving lymphatics. So again, that's what I believe. And I think, you know, again, with a bit of experience and with the excellent vision afforded by a loop, if you're careful about not dividing anything that you don't identify, there's really very little risk.
Okay. And in a given Carroll's patch, if there are multiple arteries which are quite far away from each other, say 3 centimeter, 4 centimeter, in that situation, what do? You use that big Carroll patch, or you separate the arteries and anastomose them?
I'll never use a 4 centimeter Carroll patch. I mean, there are many things you can do, and it all depends on you know your experience and on the situation, on the vessels available to you on the recipient side. You can do two separate anastomoses with the recipient's vessels, or you can, if you can bring them together, you can do a pantaloon side-to-side anastomosis, or it's also been described, although I've never done it, that you can anastomose the two small Carroll patches together on a bench, creating a slightly bigger Carroll's patch, and then using that for transplant. So again, there's a whole range of options.
Thank you. Dr. Pranjal Modi, you have seen this injury.
Dr. Ajay, Dr.
Yes,
Ajay, you're behind schedule. I think you should stick to your time.
Okay, right, sir. Then I'll stop the presentation by Jamal here. Over to you, Dr. Swaminathan. Please proceed. Dr. Swaminathan. Dr. Swaminathan.
Yeah, good evening, everyone. Thank you, Dr. Ajay, and thank you, Urology Society of India, for giving me this wonderful opportunity to talk about retrieval injuries. I'll just share my screen now. All right, thank you. So since most of the speakers covered about the essential steps of organ retrieval, I'm going to stick on to only the retrieval related injuries. What are all the key steps, or what are the precautions that we need to take, and some of the key steps to avoid these injuries, and if it happens, and how you're going to deal with that. I think it even starts from getting the donor's history. This is one of the DCD donor I did way back in 2010, 11 maybe. It's a DCD. I didn't get a proper history. Opened up, and we found a EVAR, an endovascular aortic graft sitting there, and it took us a lot of time before we could cut through the graft and cannulate the aorta. Unfortunately, we ended up losing the liver. we could only use the kidneys. I just want to emphasize that donor history and a good clinical assessment is very important to protect the organs and to prevent any unwanted damage or discard of organs. So expeditious assessment and recovery of organs without making any surgical damage should be the central machine. This is data from NHSBT and SRTR. Somewhere about 11 to 14% of them incur some injuries, and about 0.6 to 1.4% of the organs are discarded due to surgical damage. It's more common in DCD than in DBD, where you have a lot of time to ascertain certain things. When there are anatomical abnormalities, chances of injury are much higher, and vascular injury is probably the most common reason for the discard of organs. But remember that nowadays we have plenty of techniques up the sleeve you can use to reconstruct the vascular injuries. Kidney particularly has a higher chance of injury, as we all know that it's the last organ to be retrieved, often after the thoracic and the liver. It's often left to the less experienced in the team, and often not covered in ice. So the point to the young surgeons is that make sure that the kidneys are well covered with ice while the thoracic team's taking out their organs and the liver team's taking out their liver. Injury can happen during any phase of the retrieval. I'm going to skip all these slides. Like I think most of the other speakers also emphasized, it's very important to, when you're cannulating or when you're doing the warm phase, the dissection should be restricted distal to the IMA to avoid any polar injuries, polar arteries. Aortic cannulation, you can actually tell if the surgeon is an experienced retrieval surgeon by the way he does the cannulation. Good cannulation is essential to achieve adequate perfusion, in situ perfusion. As mentioned by other speakers, do not push the cannula above more than 4 centimeters above the bifurcation, and IMA is a good origin of IMA is a good marker, and you don't want to push it beyond that, otherwise the renals won't get perfused properly. Sometimes we do encounter a lot of difficulties, particularly in obese, hypertensive, diabetic, hypertensive donors, lots of atheromas, but you'll always find a soft spot in the aorta. If very rarely we had to cannulate the iliacs, but beware when you can.
Please hurry up.
Yeah. Occasionally you can do a retrograde cannulation, but when there is atheroma, just remember there is renal osteostenosis. There could be renal osteostenosis. Just beware of poor perfusion and be prepared to perfuse in the back table. Lots of ice, as I mentioned before, and because the core temperature can rise very easily to 4 degrees more than the in situ flushing. The temperature can be as high as 10 to 12, and if you don't cover it twice, it can go up to 4 degrees higher, and it can lead to significant ischemic injury. I think these are by previous speakers. In the in situ, I prefer an in situ purely because you just can quickly open the antiwall of the aorta and see the bus and give a nice cuff around both the renals. And if there are any polar arteries, they're usually in the same plane. You should be able to see the polar arteries inside, so you don't damage it. And then the rest of the technique is the same. And it's always good to get some vessels. If there is no pancreas retrieval, get the other set of iliac artery and vein and share it between the 2 kidneys. It may be handy in case if there is any retrieval related injuries. So the common injuries and problems we encounter: non-perfused kidneys, particularly if there is an atheromatous aorta and the kidneys are not perfused, cannula pushed up too much high, you end up with a non-perfused kidney. Capsular injuries, venous injury, arterial injuries. In fact, over-enthusiastic stretching of the organs can lead to intimal dissection, which is far more worse than having an overt injury. At least that can be reconstructed, and these ones go undetected and often come to light only when you reperfuse the kidneys with completely non-perfused kidneys. Ureteric injuries can be skeletonization or short ureter. As soon as you take out the kidney, what I do normally is to remove a little bit of fat to make sure that the kidneys are perfused adequately. If not, I always give about 200 to 250 ml in the back table as well, just to ensure to increase the core temperature, to reduce the core temperature, as well as to flush out the remnant blood. And if there is any atheroma around the renal ostium, then I would just cut back on the patch and just perfuse it behind it. Always be prepared for any surprises. This is one of the recent kidneys we got. After we took out, there was actually perfused kidney. You can see that the aorta is fairly clean, and renal orifices are not bad, but still the kidneys looked terribly perfused. We put these kidneys on machine, but it didn't still seem to work. So we discarded those kidneys. We exactly don't know whether the cannula went up or whether it didn't get perfused at all. While clearing the fat, be careful because some of the, when you freeze the kidney or when you cool the kidney, pack it for a long time, and when you take it out, the fat can get really frozen and get stuck to the capsule. And particularly in older donors and smokers, fat can get to the capsule, and this happened to one of our cases where while taking the fat out, the capsule came off completely. We managed to cover it with some Surgicel and use the kidney and spread some Tissel over, and it worked well. Luckily, it didn't go for a page kidney. Right kidney, I think Dr. Jamal very beautifully showed a video with IVC. It's always a good practice to get the IVC with the right vein, but we often get kidneys imported, come from other centers without the IVC. It's good to have the IVC for extension. As he showed, you can cut the IVC and extend it. In fact, if given a choice to me, I would take a right kidney purely because if I have an obese recipient, I can extend it with the IVC and use it comfortably. This is another way of reconstructing when the cut was too close to the renal vein. And this is the right vein extension of IVC when the cut was too close. But it's never been a problem because as a liver surgeon, I never needed the lower end of the cava. So I'd always give a lot of cava for the renal guys to take with them. This is one of the right kidneys where the IVC was not even with the graft, and the kidney was right vein was open. We didn't have any vessels to reconstruct. What I basically gated the internal iliac vein and then lifted up the external iliac vein and just implanted directly. With the lab donor right nephrectomies, surgeons, recipient surgeons are getting adept and using different techniques. And this is you can see that the vein is completely longitudinally. I don't know how it happened, but this is one of the shipped kidneys, and we just longitudinally repaired it with a 7-O-proline and then use kidney. This is another right kidney. You can see that cava was not even there. It's completely if you use a standard retrieval technique like what the previous speakers explained, the cava should come as a full tube with right vein. It makes our life very easier. But this is still possible. You just use a nice cuff of the cava, and we implant the kidney. This is a renal vein which is completely transected at the hilar level. We managed to pick up some vessels from the liver team and extended the renal vein, iliac vein from the up, and then that's an extension, and then put it down and then implanted it. This was done almost like 24 hours later with a cold ischemia of 24 hours, and being a young kidney, it just worked fantastic. As we all know, there are so many aberrant arterial anatomy, but remember, inferior polar artery gives vascular supply to the urethra. Ensure that the inferior, if there is any inferior polar artery, please do reperfuse it. So this is, back table, although is a simple procedure, wear a loop. This is one of the back table injury. Yeah, this is a back table injury. Sorry, this is a back table injury where the artery was cut. We had to use straight away repaired with no-proline. This is early branching of renal artery. Again, this was damaged during primarily repaired with a continuous or an interrupted 7-O-proline. Again, double renal artery. This is where the origin of the second artery was, upper polar artery, which was completely cut at the level of hilum. And you can see in the other picture that length is still there. So I just dissected a little bit more and implanted as two separate onto the iliacs. There's another situation where two arteries were cut extremely close to the hilum, managed to implant separately, or in one of the occasions, I don't have the picture though, I've implanted one to the internal iliac and another one to the external iliac. So there are so many ways you can reconstruct any injuries. Either it can be connected to the side of the main artery if it's too short, or it can be connected, if you have enough length, you can connect it to the external iliac as two separate anastomosis. It can be connected to the internal iliac and external iliac as two different anastomosis. Ureteric injuries, I don't think I need to talk too much about that to a group of urologists here. The injuries that we can often see is calcinization of urine, ureters. So just make sure that you leave plenty of fat around it. It can be cleared in the back table and preserve the golden triangle. Short ureters, I've used a Bowery flap once or twice, and only once I've used native ureterostomy almost at the level of pelviureteric junction with only like half a centimeter of ureter. So I just swung
please, Swaminathan.
That's it. I think I'm concluding there. So just
this has already been covered by Jamal. So yeah, can I request you to stop in the interest of time?
Yeah, sure, no problem. That's the end of the last slide. So thank you very much. Yeah.
So in the interest of time, I stop the first session here and hand over the proceedings to Dr. Jamal, please.
Yeah, thank you, Ajay. So, we're surgeons and we like surgical things, and this was a very surgical session. But we should also be concerned about, if we're going to work in deceased donor organ transplant, about organ sharing, as this is a very important aspect that affects our patients, our practices, and our programs. Now, organ allotment and organ sharing is a really important part of deceased donor transplantation. It has many facets, including medical, surgical, immunological, logistics, and ethical. So to enlighten us about this, we have a very distinguished panel of people who are leaders in their fields, both in India and in the West. And we'll ask them to enlighten us about how organs are shared. I mean, we'd really like to know about how they're shared in India, and organ allocation being a dynamic process, what changes can come and how we can improve even further. So again, without ado, I'll call upon Ms. Vasanti Ramesh, who needs no introduction to all of us. She is the director of the National Organ and Tissue Transplant Organization, where she has promoted data sharing, collection and sharing with a global observatory. She's also a member of the advisory panel of the Tribute to Life Board of the NHS-BT UK, and she was recently awarded the Women in Transplant Award of the Transplantation Society. So I'll request Vasanti Ramesh, Madam, to tell us about the functioning of NATO.
Thank you very much, Professor Jamal Rizvi. I witnessed your video and really was in awe at the excellent dissection that you were doing. And thank you very much, Dr. Oswal, for having invited me today to share about the organ allocation policies in the country. And without wasting further time, I think I will just start sharing the screen. Good evening, everybody. I thank the Urological Society and all the surgeons and physicians and all the people assembled here for this webinar. And it is indeed a great occasion where we would like to share the organ allocation policies in the country. To begin with, what does the rules say? The Transplantation of Human Organs and Tissues Rule, number 31, that there would be a national networking organization at the center along with regional and state networking organizations as the central government may by notification specify. And these state units are to be linked to the hospitals, labs, tissue banks, as well as to the regional and national networks so that allocation process can go on. The online system of networking and formats will be developed by the Apex organization, and the same are to be followed by the states and the UTs. AFMS can have their own policy. The networking should be enabled and accessible to a dedicated website. The allocation criteria have been developed and they will be updated regularly by the networking organizations. The NOTO allocation criteria are available on our website. The website of the Transplant Center requires to be linked to the state, regional and national networks through an online system. This is for organ procurement, sharing and transplantation. The patient may get registered only through one transplant center and upload the details online to the networking organization, whereby a unique ID will be allocated, and this will remain same even if the patient changes the hospital. The state allocation will be decided by the SOTOs and NOTO in the case of Delhi. The priority of listing for deceased donors would be as follows. Those who do not have any suitable living donor among their near relatives would be top priority. Those who have a suitable living donor available, but the donor has refused in writing, would be the next priority. And the last would be one who has a suitable living donor and who has also not refused to donate in writing. The sequence of allocation of the organs would be state list followed by the regional list and then the national list, all these for Indian patients. Then after this, the allocation can be made to a person of Indian origin and then to a foreigner. The last three are done at the level of NOTO. The SOTO, ROTO and NOTO shall coordinate retrieval, storage, transportation, matching, allocation and transplantation of organs and tissues, and shall also develop norms and SOPs, and designated organ and tissue retrieval teams can be created in state, district and institution, like how they have in the NHS BT, or it could be at the institutional level alone. The allocation criteria, the general criteria are the patient has to be registered, as I told you, on the NOTO website, and the patient only in one hospital. For deceased donor, it can be done even when a patient is waiting for a living donor transplant. The status of the listed patient must be updated by the hospital monthly. For super urgent patients, updation is required daily. In the listing, the status of the patient must be updated regularly by the hospital in one of the following status: either active or unfit due to medical reasons or whatever, or if it is suspended. Sometimes many people say that the patients are lost to follow-up, then it should be reflected. If the patient is transplanted, again, that should be entered in the registry, or if the patient has died on the waiting list. The general principles of allocation are: if an organ has arisen in a city, first the city waiting list is considered. If there is no patient in the city, then the state waiting list is considered, following which in the region and then at the national level. A pediatric donor organ will be allocated to a pediatric recipient. A blood group O donor organ would go to an O recipient only. Only if there is no O group patient on the wait list would it be allocated to other groups, and the sequence would be to first to group A, then to group B, and lastly to group AB. If the donor is either A or B, the organ would go first to the respective blood group, that is A or B, and lastly to AB. Of course, when it is AB, it will go only to AB. The general allocation algorithm would be the blood group is checked that it is same. Then if there is a super urgent patient, that would be the first priority. If there is no super urgent patient, the next priority would be for a multi-organ transplant. If that is also not there, then it will go to a single organ. If the transplant center has facility for transplanting all the organs, then all the organs and one kidney will go to that center, transplant center from where retrieval has happened, and the second kidney would go to the common pool. If the transplant center does not have facility for certain organs, that would also go to the common pool, and in case of NTORC, all organs will go to the common pool. The allocation priority would be from a government hospital to a government hospital, and from a private to a private. That would be the first priority. If it is not available, then from a government, it can go to a combined list, government and private, and lastly to a private hospital list. And the other way around, from a private, then to the combined list, and then to the government hospital. All SOTOs will broadly follow the same guidelines and protocols for organ allocation, though they may add certain state-specific issues in consultation with these respective SOTO. A hospital that gets an organ for a super urgent patient will forego its next turn and go to the bottom of the list in the rota. When it is a marginal donor refused by other centers, then the hospital which gets it will not lose its priority in the next round of allocation. In case an liver is split, then it is allowed to use for the second recipient in the same center if they have a recipient who is registered with the SOTO, or it can be offered to another center to a patient who is registered on the NOTO website. But in all cases, foreigners will be the last priority, allocation to be done by NOTO only after the organ is not used for any Indian patient and person of Indian origin. This clause will override any center-specific waiting list. Coming to kidney, which most of you are interested, the patient registration can be made if he or she is 75 years or less, with at least 3 months on regular dialysis and with no absolute contraindication. For urgent listing, patient has no access to dialysis and cannot be therefore maintained on dialysis, or has more than 90% panel reactive antibody. This can be reviewed every 3 months. Applicable to all organs is each hospital should maintain their own waiting list, and this should be available on the National Registry on the NOTO website. Once an organ is allocated to a hospital, the organ will be used only in the recipient previously registered on the national website at least 48 hours before the allocation, as per the seniority on the waiting list. The scoring system that has been devised is based on the time of dialysis +1 for each month, for immunological graft failure +3 for each graft failure, according to age +1 for less than 6 years, for 6 to 12 years, and for 12 to less than 18 years. For patients on temporary vascular access, all AV fistulas fail +2, all AV fistulas and AV graft fail +4, PRA 0.5 plus for every 10% over every 20% PRA. Previous living donor now requiring a kidney transplant +5 points, and near relative of a previous deceased donor also would get +5 points. The patient registration for liver would be done if he or she is 65 years or less at the time of registration with a MELD of more than 15 in decompensated cirrhosis, and in hepatocellular carcinoma it would be as per UCSF criteria. Metabolic disorders, quality of life issues, etc., minimum required MELD score is not there, so these are at the moment not listed for deceased donor transplants. Super urgent listing in liver can be done in primary non-function of the liver allograft, living donor who develops life-threatening liver failure, early hepatic artery thrombosis requiring a retransplant, fulminant hepatic failure who meets the King's College Hospital criteria. Contraindications to listing are less than 15 melt, unfit for GA, patient with AIDS, HCC beyond the UCSF criteria, uncontrolled sepsis, intrahepatic cholangiocarcinoma, extrahepatic malignancies. Allocation criteria for deceased donor heart and lung transplant would be based on the following priority. Emergency would be those on VAD, IABP, all this, and still critical. Priority based on blood group and size match, status to be confirmed on weekly basis. Semi-emergency is patients on ICU, on inotropes for at least 1 week, not maintaining hemodynamics without inotropes or weaned, and the category requires to be updated every 48 hours. Based on the progress, the patient may stay in priority 2 or shift up or down. The status to be confirmed by a 3-member heart subcommittee. Then the elective heart and lung transplant patients are those who are electively waiting for a transplant, and the status to be confirmed or changed on monthly basis. The criteria for allocation would be that the size and weight should match, the mismatch should not be more than 20%. A small heart is not acceptable for large patients. Even in the mismatch, a larger organ may be fitted in a smaller patient, but a smaller patient for a larger sized recipient is not advisable. And the distance is of importance because of the short cold ischemia, transplant center. But if they require to use both lungs, then at the discretion of the transplant team, that can be allocated. The other lung will go to the general pool and allocated to through the respective SOTO. Thank you very much for your patience. And this is the broad allocation criteria that has been defined by NOTO.
Thank you, ma'am, for that very informative lecture. And although we're short of time, I can invite a couple of questions from the audience. And until those come, I just have a question. Do the kidney rules allow the use of both kidneys into one recipient, a dual kidney transplant, in case of expanded criteria donor kidneys?
Yes, in expanded criteria donors, use of both kidneys may be allowed if one kidney cannot be allocated to a donor and that it would function. So that assessment would have to be made.
Right, and this decision would be made by who? By the retrieving team or by the hospitals to whom it was offered?
Made by the networking organization, the SOTO.
Right.
Sir, I got a question.
Yeah,
Madam,
go on, because
once in a while we have a situation where, you know, the deceased donor demands that one of the organs should go to one of his relatives. What's your take on that?
The law doesn't permit it. There is no provision in the law for such a...
Even if they refuse based on this fact?
Yes.
It has been permitted once in Mumbai. Directed donation has been permitted by the court.
See, those may be, you know, a one-off instance, but it cannot become a routine.
So there's a question from Matthew Wadsworth.
It will become very difficult for everyone to handle.
So there's a question from Matthew Wadsworth, who's going to be the last speaker on this panel, and he asks, are there circumstances where allocation of an organ is expedited outside the guidelines to prevent the discard of the organ?
What do you mean by that?
Matthew, if you could come on the mic and you could put a question directly to Dr. Ramesh.
So are there times where you're forced to allocate the organ outside the traditional system in order to prevent it from being discarded? Say a recipient where you were to discover a recipient could receive that organ at the last second. So as opposed to losing the organ, you place it outside the traditional hierarchy.
You're not clearly audible, Dr. Matthews.
Oh, I'm sorry. So if the kidney couldn't be transplanted into the patient, the intended recipient, are there circumstances where you will allocate the kidney outside traditional allocation rules?
You mean if the recipient became sick at the last minute and you were left with a kidney without a taker, you give it to the nearest available taker? Is that what you're asking?
Yes.
No, that is possible. It is not against the rule. If an organ has been allocated to somebody, if in the last minute, it is not possible to use for that patient, then the next patient on the waiting list will get the organ.
Right. Thank you, ma'am. Thank you very much, ma'am. And if there are no further questions, we'll go on to the next speaker. Next speaker is
Professor Jamal and Dr. Asma.
Is Astrid Lobo Gajiwala. So again, she's well known to those in the transplant community. She's the ex-director of Roto and Soto of Mumbai and currently co-chairperson of Roto and Soto West Zone. She's also the former president of the Asia Pacific Association of Surgical Tissue Banking, and she's established the country's first tissue bank at Tata Memorial Hospital in Mumbai. So I think she's the right person to talk to us about the function of Roto. And I hand over the mic to Astrid Lobo Gajiwala.
Thank you so much, Professor Jamal, and thank you to the organizers for giving me this opportunity. So, Dr. Ramesh has already, given a lot of the details with regard to allocation. So I'll just touch on a little specifics with regard to the state. So, first of all, what happens is the patient will first get registered in a transplant center in the state. And as you've already heard, there is only one registration per state. Multiple registrations are not permitted. If there is no transplant center in the state, then it's possible for the patient to get registered in any of the other states in the region. Then the transplant hospital will then register the patient with both SOTO as well as NOTO. And the allocation of organs within the state will be decided by SOTO. Organ sharing and networking policies of the states is not binding on the armed force medical services, but in Maharashtra, for instance, we have two hospitals which belong to the armed forces. And although this policy is not binding on them, they have opted to be part of the system. So they function like any other transplant hospital. Now, the sequence has already been told to you: state, regional, national, person of Indian origin, and foreigner. As far as the foreigner is concerned, the state does not allocate. This allocation is solely done by NOTO. Now, the principles of allocation that we follow are, again, exactly what Dr. Vasanthi Ramesh has already said. That first of all, you have the super urgent category. We usually do this only for liver or heart and lungs. Then you have, of course, the blood group compatibility. And like Dr. Ramesh has mentioned, you have, first of all, where you have the blood group is identical. And then, of course, in the case of the O group, you have either the recipient also is of the O group. And if there is no suitable recipient, then it will go to any of the other groups. And once again, here you follow the same list in terms of first the hospital where the donor was, then the city list, and finally the state list. And of course, there is a priority here. So for instance, if there is a super urgent category of either A or B, then it is possible that the O donor, the organ will go to these. Okay, then you have multivisceral transplant. So here again, there is a priority, and this priority depends upon the life-saving potential of the organ. So the priority that is followed is you have heart, lung, intestine, liver, pancreas, kidney, and then composite tissue, including hand. So basically the way it works is that if the person is allocated an organ higher in the list, and also needs an organ lower in the list, then they will get both the organs. But the other way doesn't work. So for instance, if somebody needs a heart and a liver, if the heart is available, the person will also get the liver if it's available. But if the person is allocated the liver and the heart is not available, then the person will not get the liver also. So this is the way it functions. Then, of course, in Maharashtra, we have a slightly different system from other states because we have what is, the Maharashtra system actually started a long time ago. I think it was probably one of the first in the country. And at that time, they had formed the zonal transplant coordination centers. So the whole state is divided into 4 zones, Aurangabad, Mumbai, Nagpur, and Pune. And each of these have these ZTCCs. So the allocation at the zonal level happens through the ZTCCs. So what happens is you have the patient will register with the hospital, and the hospital will then register with the ZTCC. Now, if an organ is not, so when there is an organ available in the city, then the ZTCC in which that city is located will allocate the organs. If there is no suitable recipient in the zone, then it will come to SOTO, and SOTO will allocate the organs across the zones. Similarly, we have also the region. So in the region, we have Chhattisgarh, Goa, Gujarat, Madhya Pradesh, Maharashtra, Daman and Diu, and Dadra and Nagar Haveli. And here also the SOTO, well, here we have the ROTO and SOTO are together in Mumbai. So the ROTO will handle the allocation of organs across the state when they become available in the region. And then, of course, all across regions, the allocation is done by NOTO. Then you have organs which are offered by NOTO. Dr. Vasanti has already mentioned, how this is done by NOTO. So NOTO actually will allocate the organs even to the states. And then within the states, once again, SOTO will then allocate to the different zones in the case of Maharashtra. And this will then go according to the distribution policy of the ZTCCs. And in all cases, if there is a super urgent case, then of course that patient will get priorities. Now, this is the allocation which is done in Maharashtra. So here there is for kidney, there is a scoring system which is used. And here you have if there is a PRA positive, for either PRA1 or 2, you will get 0.5. Then the different age groups, 3 to 5, 6 to 10, 11 to 45 years. So you have accordingly 3, 2, and 1 points. Then the period of dialysis is counted as 0.1 point per month on dialysis. If there has been a transplant failure, whether it is living or a deceased donor, then the patient is given 2 points. And finally, if the donor and the recipient are of the identical age group, then they get the additional 2 points. Okay, now the allocation of the liver. So here you have the super urgent category comes into play. And here what happens is the hospitals will provide all the details of the super urgent of the critical patients. And all these will be reviewed by a ROTO-SOTO expert committee, and which will then approve that, yes, this patient is very critical. And in the case of the liver, the super urgent patients will get priority only at a zonal level. That means only when the organs are available within the particular zone. Like I said, there were 4 different zones. The remaining, if it's a donor hospital patient, then on the basis of the blood group and the date of registration is the way that the allocation goes. And finally, you have the city waiting list, which is again on the basis of blood group and the date and time of registration. Sorry. And finally, you have the allocation of heart and lungs. Once again, you have the super urgent patients, which again are approved by the ROTO-SOTO expert committee. And the heart, and here in this case, you get priority is at the state level. So if there is a super urgent case, no matter where the heart and lungs are available, then this patient, no matter where they're available in the state, then this patient gets a preference. And the routine is, of course, according to chronology. This is just to give you an idea of the allocation of organs. So they can be allocated within the state. You have allocation through ROTO, that is organs offered by ROTO, the different states in ROTO, or you have allocated through NOTO. Here again, you could it could either go out from the state or we could be receiving from NOTO. And you can see the numbers there. So 2020 was not such a good year because of COVID, but otherwise on an average, there are around 400 organs retrieved and transplanted in the year. So in conclusion, just to say that this network works well, and thanks to this network, it facilitates organ sharing, not just within the state or within a city, but right across the country. And so this also helps to reduce the wastage of organs. So thank you.
Yeah, thank you, Dr. Gajiwala, for a very lucid explanation of the functioning of the Maharashtra ROTO. I have a question for you and also for Dr. Basanti Ramesh and also Dr. Pranjal who's here. I mean, there are maybe slightly differing policies for who can register in various states, and every state has its own rules for this. And health being a state subject, naturally the states have freedom to generate these rules. But do you think these rules are going to clash and advantage or disadvantage patients from certain states?
At the moment, see, when it's within the state, there is not a problem. But I think it's when it goes across the state that this issue would come up. And then the NOTO guidelines come, and it's uniform across the country. The guidelines that the NOTO uses. So it and really you have the patients are registered only within a particular state. So you don't have patients who are registered in different states. So so yes, there may be slight differences between the allocation criteria in different states, but I don't think it really affects the patient.
Right. There's a question from the audience. The question is it not mandatory for ROTO or SOTO to follow uniform NOTO guidelines? Which is similar to the question that I had put. I mean,
actually, according to the law, no. According to the law, every state has the freedom to make its own guidelines.
Right. Right. So thank you, Dr. Gajiwala. And if there are no further questions from the audience, I'll hand over the mic to Dr. Pranjal Modi, again, who requires no introduction, being a man who wears many hats. He's the Vice Chancellor of the Gujarati University of Transplantation Sciences, also the Head of Department of Urology and Abdominal Organ Transplant at ITDRC Ahmedabad, and also the convener of the Gujarat State SOTO. And he's established liver transplantation in the public sector in Gujarat and also pioneered robotic kidney transplant. So I'll request Dr. Pranjal Modi to tell us about the functioning of the Gujarat SOTO.
Thank you, Dr. Jamal. I will be very brief because most of the part has been covered by the two previous speakers. The SOTO Gujarat is the last SOTO probably, and it was established in 2019. The principles of organ allocation primarily were adopted from Tamil Nadu model and also from the NOTO, which has also made the Tamil Nadu model. So rules are made, or the observations are made from the Tamil Nadu model were very useful. Mohan Foundation data were also studied very carefully before we make this particular allocation system. Next is, next. Next, yeah, okay. So the point considered were in a previous allocation system, there was no immunological parameters discussed in detail, and especially the anti-HLA antibodies, which are responsible for the early or late graft loss. And also there is a concern about virtual cross match between the donor and recipient, if it is possible, which is again based on the HLA matching. So I think a careful consideration was made in making the new rules. I think there is some issue with my laptop. Just a minute. It's not moving. Yes. So let me go back. So there is a point system. What are the point system here is the point are allocated according to HLA base. Like B locus, the one of the, if anti-HL antibodies are present against the B locus, then probably that is zero mismatch. It is given 1 point. Mismatch is 1 mismatch is 0.5 and 2 mismatch is none. Same thing is DR locus is very important. If there is zero mismatch, points are 2, 1 mismatch is 1, and the 2 mismatches are then 0. So same thing is PR activity, as we know that if the if patient is having the 25 to 30% positive PR activity, the average time in a UNOS database, we have found out that it is around 450 days to get the organ. But if it is around 75 to 90% positivity, then it takes about more than 1,000 days to get the appropriate organ. So accordingly, the scoring system has been given, a point has been given. Same thing is children are to be promoted for transplant, and all organs, not only that pediatric organs will go to the pediatric patient, but there is also allocation system here where 6 points are allocated to the very young children, while if it is close to 18 years of age, then there is a 0 point. Bonus point for who was a kidney donor is almost similar in the other system. Bonus point for zero antigen means full house match is getting 6 points, and the waiting time is also given more and more waiting time, because we all know dialysis vintage period is longer than outcome of transplant also are reducing, and they should be getting the early organs. Bonus point based on ABO incompatible near relative when patient's blood group is A and B. This has not been in any of the other guideline, but it has been there in the Gujarat guideline. And here we give a -6 point because they have a donor, but then nobody wants to donate also. So they get a -6 point, especially when A or B. It is very easy to do a paired kidney exchange. If there is an O blood group, that is difficult to do paired kidney exchange, but still it is possible. So they receive -3 points. Bonus point based on maintenance dialysis for greater than 3 months at the time of allotment is like if there is no dialysis, then it's -6 point. There are some patients who are not on dialysis, but they get so that they get a -6 points. When the recipient is retransplanted, again the points are given like this. And female recipient, because in India we found that there is gender difference, so that females are promoted by 2 points compared to the male patient. And also there is this incorporation of the donor specific antibody. If the MFI is less than 5,000, the 2 points. It's for single antigen, single antigen. If it is less than 5,000, 5,000 to 10,000 is 4 points. In severely sensitized patients, and 6 points. And if more than 3 donor specific antibodies are present, then it is 8 points. Now, willing for list exchange has not been implemented at this point of time, but it is provisional is there. And then because there is no law prevailing in the state of Gujarat and also at national level, the exchange of the paired kidney exchange from the living donor to the deceased donor, and this is vice versa. So in a list of paired kidney exchange, the intended recipient receive priority on the deceased donor wait list after the ABO or HLA incompatible family donor donates the kidney to a deceased donor waiting list candidate. In list paired exchange, the patient should get standard criteria, deceased donor kidney less than 50 years of age, and the not expanded criteria donor. However, this has not been applicable at this point of time, but it is already there into the SOTO allocation system. The family, the 0.8 and 0.9 are considered as a family. Family definition is very clearly given in the Transplantation of Human Organ Act, and accordingly we have to follow. Now, as far as allocation of kidney is concerned, there is only a point system. There is no urgent point system, and there is no priority list into the kidney point, because all these factors are associated with the medical priority only. So I think it is very important to consider that the only point system should be followed, and there should not be bypass in an allocation of the kidney. While in case of heart, lung, liver, and pancreas, there is an urgency, and especially in pancreas, there is no urgent, but it is usually given priority when the diabetic patient is to get the get the kidney. Now, sharing of organs for waitlisted recipient retrieved from the cadaver donor. So if it is from the government hospital, the first priority will be to the government hospital itself. In Gujarat, at present, there is only one government hospital which is doing transplant, and that is IKDRC ITS. But in future, there may be many more. However, at this point of time, the organs are from the, if they are from the Medicity, that is in the campus of the civil hospital, there are 6 or 7 hospitals. And if the deceased donor is in this campus, the organ will be considered as going to the IKDRC only. First priority will be there. However, if they're outside the campus, means that government hospital anywhere in Gujarat other than in Ahmedabad, which is in a Medicity campus, then there is a rota system, and according to that, the first, third, and fifth donor organs will go to the government hospital. Priority will be given to the government hospital patient, and second and fourth will be going to the common pool of the, to the private hospitals common pool. And again, there will be new rota system. So there is a favor to some extent to the government hospital, like the first 135. Again, there will be 135. So like after fifth, again, there will be a chance that government hospital is going to get the organ. Government, if their organs are not utilized, it will be going to the common pool. Now, cadaver allocation of non-government hospital, again, the first priority is to that particular hospital where the deceased donor is present. So all organ locally can be utilized. If that, like that hospital is licensed to do the transplant of a kidney, liver, heart, pancreas, everything, then all organ can be utilized at the same place. There will not be sharing. However, if that hospital is no using the all organs, or it's not licensed to do that, then organ will be shared to the common pool. And so that is also very important, with difference than the other sharing system. Now, what is common pool? That is the first come first serve basis will be applied to the common demand register of the transplant. And every patient who are in need of organ, that is just a, I think this is the mechanism, not a very important slide otherwise. And this is the Noto-Roto-Soto system. And finally, the pediatric cadaver donor will be allocated to the pediatric patient in transplant waiting list. Now, there was a question about exception for the allotment. I think it is clearly defined in a Gujarat state, is when an organs are successfully transplanted from brain stem dead donor, his or her near blood relative, like husband and wife, parents or son, daughter, brother or sister, grandfather or grandmother, or granddaughter or grandson, priority will be given to the organ which was donated and only once within 10 years of donation. This is just to promote the more and more organ donation. Thus, the member of the family, according to the standard criteria of the deceased donor, that is defined by the THOA rules 2014, which is mentioned above, like the husband, wife, parent, or sons and daughter and brother or sister. If necessary, organ transplantation priority list for one organ transplantation will be given to the waiting list. However, there are no, the permission from the appropriate authorization committee of the state is must before we allocate the organs from that. The convener can do if there is a deceased donor available and immediately there is a, at the same time when the near relative is requiring the organ, so he can allocate directly. But in case at that time, the requirement is not there, but after a few years, like some relative is getting the organ failure and require transplant, at that time also the priority can be given. Thank you very much.
So thank you, Pranjal Bhai, for that very informative talk on the functioning of the Gujarat SOTO. And again, I'd invite questions from the audience. If in the meantime, I think the Gujarat SOTO model is fairly innovative in that it incorporates a lot of immunological considerations in the attempt to reduce immunological mismatch, as well as several social considerations. For example, allotting to looking at the available donors of the family, and also giving priority to the relatives of deceased organ donors. I mean, I would just because I'm just curious about whether these are prevalent in other states also. Again, this question is to either Pranjubhai or to Dr. Astrid or to Dr. Ramesh.
I don't think so. Right now, it is the same system is there in any other state, but probably this was prepared in a very late part of the, like as I mentioned, Gujarat Soto was the one of the last Soto, and hence a lot of thinking was made, and a lot of ultimately the outcome of transplant are very important. Long-term outcome of transplant are very important, and we all know that lymphocyte cross-match alone is not going to work. So there is a role of anti-HL antibodies, and especially the class 2 antibodies when they are present, then the allograft function is not going to last longer, and hence a lot of nephrology involvement was there when these rules were made, or where the allocation system was made at that point of time. Most of the allocation thing has come from IKDRC itself, and it was agreed by most of the nephrologists of the state. So accordingly, this was made. And also, you know that a paired kidney exchange is a very important thing, and we need to do the more number of transplant. So if there is a possibility of a living donor versus deceased donor paired kidney exchange, then this is possible. The one more question was asked by Dr. I think from United States, is out of the waiting list criteria when you want to allocate the organ or so. I think we need to think very broadly at this point of time. And even in the United States, some of the centers have done the paired organ exchange, like a liver donor, liver patient can donate the kidney, and kidney patient can donate the half of the liver and as a living donor. So all these things need to be really added upon, and so that number of patients dying because of the lack of or unavailability of the organ transplantation can be reduced significantly. And we need to improve our organ allocation system and transplant program in accordingly. Thank you.
Organ allocation is a dynamic process, and these systems keep changing and evolving over time. And hopefully we can learn something from our next two speakers. Just a couple of questions from the audience. Dr. Mallikarjun asks, how about guidelines on multi-organ transplantation in Gujarat?
Yes, so it's very important question. When there is a need of a multi-organ transplant, that is the number one priority, and especially for the patient who require combined liver kidney transplant or so. We also, to encourage the pancreas transplant, we also have incorporated a combined pancreas and kidney transplant as a priority, especially because we all know that yes, diabetic recipient can have only kidney transplant, but if there is a combined pancreas and kidney transplant, they can get a early priority, and they are difficult to dialyze for a long time, and hence priority has been allocated at this point of time, which is often not there in a western part of the world, but I think we have considered that part to benefit this group of patients. As the other transplant like combined heart and liver and all these things are still not at this point of time happening in state, but if it is needed, probably we can update our guideline that heart and liver transplant and heart, liver and kidney transplant, etc., or multivisceral transplant. These laws are not being made yet. Probably those facilities are not available at this point of time. Thank you.
Right. So one last question from Dr. Ajay Oswal, and then we'll probably go on to the next presentation because of a shortage of time. Although this discussion
Professor Jamal and Professor Pranjal and Dr. Jamal, in insisting on HLA reports and so many immunological parameters, is lot of time is not wasted before the allocation of organ?
The average time required for the transplantation is anything between 12 to 18 hours, right? In occasional cases, it has gone up to 22 hours. But I think it is very important, and it is not wasted time. What we get is that we get an early blood sample from in a two standard laboratory, which has been decided right now. One is IKDRC, another one is a private laboratory. So after the first apnea test, we send the blood sample. So there are 6 hours already available for the second apnea test to carry it out. And the second apnea test is happening, patient is brain dead, then and then the HLA report has been declared, and then we get HLA report within 6 hours or 8 hours time, or maybe sometime even 12 hours time, but it is not having a lot of wastage of time. That much cold ischemia time is very well accepted by most of the surgeons and centers.
Right. Just one last question from Dr. Mallikarjun. The question is, since Gujarat has paired kidney donation and waiting list and deceased donors is capturing the ABOI donor, would linking both be a good option and increase the donor pool? So
Yes, this is to increase the
that's
donor
the
pool.
that you mentioned.
Yes, I think this is to increase the donor pool, but it has not been implemented yet because we don't have a clear-cut guideline about these things. But we are making it, and maybe in a short future, probably it will be implemented in Gujarat.
Okay, and one last question: who bears the cost of HLA typing? It's from Dr. Anurag Shrimal.
Yes, I think usually when the kidney goes to the IKDRC or the organs are going to the government hospital, usually the government hospital bears it. If the organ, or if government hospital is not getting any organ, and if it goes outside, then the private hospital who are getting kidneys, they are bearing the cost of it.
Right. Thank you, Pranjal.
Thank you.
And now I'll invite Dr. Sanjay Sinha to give his talk. Sanjay is the lead for pancreas transplant and clinical director of transplant at the Oxford University Hospital Trust. He's also the vice chair of the Pancreas Advisory Group in the NHS Blood and Transplant. And his areas of interest are pancreas transplant, kidney transplant, small bowel transplant, and laparoscopic donor nephrectomy for living donors. So with this, I'd like to invite Dr. Sanjay Sinha to tell us about organ allocation policies in the UK.
Thank you to the Urological Society for this invite, and I've been listening to the talks intently, and it's been humbling to hear all those speakers who have preceded me for all the pioneering work that's been done. I've got the easy task of talking about what I could potentially call a mature transplant system, which has been in existence for some time. So I'll focus this talk primarily on kidneys, as I'm speaking to a kidney avid audience. I'll also specifically focus on just the allocation policies. And actually, Pranjal Bhai has made my job a bit easy because the Gujarat SOTO allocation policy is what the UK allocation policy looks like. So I work in Oxford, and I'm involved with NHS Blood and Transplant, which is the overarching body which oversees transplantation in the UK. It's an advantage sometimes being a small country because it's a country of 65 million. And so there are no state or regional waiting lists. There's just a national waiting list. The Kidney Advisory Group sits within NHS Blood and Transplant, and it is responsible for making any changes to kidney allocation or kidney allocation policies. And actually, it is incidental that this talk comes at a time when the kidney allocation policy in the UK has just changed. So we all know that in the early 2000s, kidney donation was primarily from deceased brain dead donors, and the policy, the allocation policy, or the allocation scheme as it was called then, reflected that. And just like Pranjal mentioned, the allocation policy was pretty much dependent on HLA. And I agree with him completely that we should not be just looking at allocation, but we should be looking at allocating kidneys to the right people and to those people where the kidney works the longest. I was interested in noticing that actually the system that the allocation systems currently exist in India actually does give some additional points to people who are coming in for repeat transplants. And I would go slightly and say, well, actually, we should be trying to make these kidneys work as long as possible so that we don't have to give extra points to people who with failed kidneys. But what has happened in the last decade or so is that the donor pool has changed. We are getting much older donors. We're getting much donors who are much sicker with many more comorbidities. And of course, there's been a huge increase in the donor population, particularly the DCD population. And the previous allocation system did not really reflect that. And that prompted NHSBT and the Kidney Advisory Board to look at how the allocation policy should work. So if you looked at the 2006 allocation policy, and the slide on the left sort of says that the whole waiting list was divided into 5 tiers actually, and the 00 mismatch pediatric patients were the highest priority, followed by other pediatric patients, followed by a fully matched adult patient, and so on and so forth. It was only the less favorably HLA matched patients who comprised the 75% of the kidneys formed the lowest tier, which was tier A. So clearly, the allocation policy favored the child or the pediatric patient on the waiting list, but also favored the better matched kidney recipient. But the situation had completely changed. And what had happened, now my slide's not moving for some reason. So what people were noticing while the previous allocation policy was working, that there were higher decline rates. And the decline rate varied from centers. Some centers would be routinely turning down 1 kidney out of every 4, whereas others would be turning down as many as every 3 kidneys out of every 4. And of course, there was a long waiting time for patients who were difficult to match. And clearly there was an inequity in the system, in the sense that if you are a patient going on the waiting list, just because you have a difficult HLA to match, you had to wait longer. And there was a lack of equity, as I would say, in the system. So the allocation policy working group was set up, and with the objective of trying to have a certain underlying principles for the allocation policy. The first and foremost was that the DBD and the DCD pool had to be unified. There should be an effective quality matching between the donor and the recipient. There's no point giving a 75-year-old kidney to a 25-year-old recipient. And of course, we've talked about HLA. There should be better HLA matching, and there needs to be equity both in terms of access on the basis of where you live, but on the basis of your race. So if you belong to a certain ethnic group and you have a rare HLA group, you should not automatically be disadvantaged. And of course, there is a recognition that the longer you are on dialysis, you do poorly. So the time on dialysis would also be taken into account. And age was thought to be a continuous factor. And what was the underlying principle here was that we should, at all costs, try to avoid long waiting times. So if you've got a difficult to match patient, you should at the outset be able to recognize them and give them some priority right at the outset. So this is what the policymakers set out to achieve. So essentially, this is what they have come up with. So all deceased donor kidneys in the UK are currently allocated through one national scheme. There is only 2 tiers of people. There's a tier A, where you have people who are 100% sensitized or who've been waiting for one reason or another for more than 7 years on the waiting list, or who are difficult to match. And there's a matchability score that people have defined, which allows them to predict such patients. And within that tier, you are, of course, will be given priority based on how long you waited on the waiting list and how long you've been on dialysis. Every other patient would go to the tier B group. And within the tier B group, there are points designed to allocate and sort of come up with a recipient score, just like Pranjal was describing. And this includes various things like the donor-recipient risk index match, HLA, where the patient is living, what are the blood group issues, etc. So just very briefly, there is a matchability score which takes your HLA into account, and it rates you from 1 to 10. If you're 1, 2, and 3, then you essentially have a common HLA group. If you're 4, 5, 6, and 7, you are difficult, you're moderate, and 8, 9, 10 is difficult. So say if you come from the say from Africa, or someone like me, an Asian man living in the UK, where the donor pool is primarily Caucasian, it's possible that my HLA I might be put down in the moderate and difficult to match group. And then the system has something inherent to it, which would allow me to have some sort of a similar equity in terms of access to transplantation. The other thing which, again, Pranjal alluded to was we have, for years together, ignored the donor risk as well as the recipient risk. Not all donors are the same. And you're lucky in India at the moment to have quite young, quite good donors. But donors in the UK generally tend to be over the age of 65, quite often have a lot of other comorbidities. And clearly that kidney will not have the same kind of outcome as a kidney from, say, a 25-year-old road traffic accident. So every donor gets categorized right at the outset from D1 to D4, and similarly recipients get categorized. And the idea being that a D1 kidney should never end up in an R4 recipient who is a high risk recipient, and vice versa, an R4 kidney should not go to an 18-year-old. And this slide is slightly complicated, but this is how the computer works things out. There's a point scoring system based on whether the recipient is R1 or whether he's R4. And of course, you might notice that within the location, if it's ideal to keep the DCDs as local as possible, so the DCD within region is getting higher points, etc., etc. And there are some deductions as well, just like I saw on Pranjal's slide, that if there is the higher the HLA mismatch, you start getting deduction in points, and you come up with a cumulative point, which sort of gives you an idea where you stand in this in the allocation system. So this is just an example as to how things are scored. So you've got a patient who is a young patient, easy to match, blood group O, who's waited 2.5 years, and for everything is getting points. And similarly, you've got a donor who is a good donor, and you would come up with a point. Sorry, I skipped that slide. And so every donor comes up with a donor number in relation to a potential recipient. DCD's kidneys used to be regional for a long time, but now, as I said, they are now shared nationally. Of course, if the idea is to not make these DCD kidneys travel a lot, it's a small country and most places are easily accessible by road in 4 to 6 hours or by a flight in an hour. So it's perhaps the problems are not the same as what Matthew would describe in the US or what you would describe, Jamal, in India. There is still some local allocation of kidneys. So not all kidneys have to be shared nationally. So young pediatric donors, not everyone is keen to transplant them en bloc, do not have the experience. So they would perhaps stay locally. If you got elderly donors who are high risk, perhaps ECD to the extreme, then they, and again, someone's talked about dual transplants, they would remain locally. But every other kidney generally is considered to be a national resource and should be shared nationally. So the idea was that if you looked at the old system, if you were a difficult to match patient, you were waiting much longer than an easy to match patient. So I would say a standard Caucasian male who is not sensitized would probably get a kidney much sooner than, I beg your pardon, than say perhaps a man of African descent or a lady of African descent who's had 2 children and perhaps is sensitized. And this new allocation system wanted to flatten out the waiting time so that there is sort of an equity in terms of access to organs. And similarly, what we didn't want was that the right donors go to the right donor organs go to the right recipients rather than have a skewed thing, so that, you know, there is almost a good age matching with regards to transplantation. So this is what the current scheme was doing. So you can see a lot of D4 kidneys were ending up in R4 recipients, D1 kidneys were ending up in R4 recipients, and some R4 kidneys were ending up in quite young recipients. The proposed scheme wanted to do this. It wanted to skew it so that you gave the right organ to the right patient, so that, as Pranjal was saying, you want these organs to work as long as possible, and you certainly don't want death with a functioning graft kind of situation. So the objectives I've already mentioned. So avoid prolonged waiting times, good effective longevity matching between the donor and recipient, and good geographical equity of access. So let's see what has happened. Obviously, COVID, as someone mentioned, hit us in 2020. The scheme was only implemented in September 2019, but it's already showing some effects. There's been a 10% increase in transplants in the highly sensitized group. 63 patients with 100% calculated reaction frequency, which is the same as PRA that was being mentioned, have been transplanted. I'm having issues with moving my slides forward. There's been 3% increase in transplants to the BAME recipients, which I said are patients who generally tended to wait longer on the waiting list. So the scheme, which was remodeled, has started achieving things what it was meant to achieve. So the median donor recipient age has shrunk. More donors are going to the right, more age-matched transplantations are happening, and the decline rate has also gone down. All the kind of things that we were hoping to achieve. So by unifying the DBD and DCD, there was this concern that DCD organs would start doing badly because they'll be traveling out of the area, but only 25% of kidneys or DCD kidneys have ended up going to TRA patients. Now, you would remember TRA patients were the 100% sensitized patients. They were the difficult to match patients who were waiting for more than 7 years. And clearly every transplant community would want to transplant these patients first. So unifying them has achieved that. 52% of these patients have gone to patients who are difficult to match just by moving out of the region. So when you start moving regions and making that national and sharing the organs more widely, as Dr. Ramesh was saying, then that is a good objective to aim for. And interestingly, there's only been a 30-minute increase in median cold ischemia time, something that surgeons are worried about all the time. Now let's look at what happened in terms of before the scheme and after the scheme. So these are 23 transplant centers who do kidneys in the UK, and the dark colored bar shows the previous scheme and the light colored blue is the new scheme. And when I look at that, there's one center which looked to have not benefited from the scheme, which is Cambridge. Now, Cambridge historically have a huge DCD program, and clearly when they started sharing it out nationally, their transplant numbers went down a bit. But we would hope that in the fullness of time, this will level out. And there were other centers which benefited the other way around. So Glasgow and the West London, which had a lot of sensitized patients. The West London had a lot of patients of the BAME community, so they have benefited. In my view, any allocation scheme, and you guys are in the process of writing these things, should ensure equity, regardless of sensitization, regardless of ethnicity, etc. And of course, in India, there are state boundaries, etc. We should all aim for optimal utilization of organs, just like Pranjal Bhai mentioned. The right organ should go to the right patient so that that organ lives the longest. We need to minimize waiting times. And of course, everywhere we need to minimize travel times and cold ischemia times and cold green corridors, etc., which I heard today is a welcome move. But what is important here is that no allocation system is ever fit for purpose and needs constant review and may need periodic tweaking time to time. The UK took almost 13 years to tweak its system, but that was in the advent of increasing donor numbers, most of whom were older and most of whom were DCD. Thank you very much.
Yeah, thank you, Sanjay. That was really good and informative. And as you say, you come from a very a mature allocation system which has been around for many decades, and probably there's a lot that we can learn here. So one question I had, you talked about longevity matching and age matching, and how you've achieved a reduction in age difference of 3 years. Maybe I missed it, but can you tell me how this is achieved? I mean, is there a difference in scoring, or do you have computer algorithms that do this automatically?
So the kidney allocation scheme automatically stops an age difference of more than 25%, and as the age difference increases, you are penalized points. So by the system has it within its scoring system something inherent which would stop a 70-year-old kidney going to a 20-year-old unless that 20-year-old is highly sensitized, and that is a full house match.
Would you give patients a say in this? I mean, suppose a desperate young patient was just wanted any kidney, would you allow them to opt for an older kidney, or?
Well, I mean, kidneys allocation happens on a named basis. So patients obviously have a right to refuse to have a transplant. The patient preference only comes in where there are issues of marginality with the donor. So if you've got a hepatitis C donor, or if you've got a donor with a malignancy, those are the kind of things that we share. But this is, perhaps I didn't make it clear, when we were drafting the allocation policy, the patient group is also represented there. So there are representatives of patients there, and they understand some of the science that has gone behind making these allocation policies. Well, I mean, if a patient asks that, what is the age of the donor, we sort of give a rough age. We don't give an exact age because you never know it may be in the news that a 70-year-old patient died in a road traffic accident, and it might get known. So you've got donor privacy to attend to. But if the donor insists, the recipient insists, you can give the age, and they may turn down the organ. I mean, at the end of the day, you can't pressurize anyone into having any transplant. It's their right to refuse it.
So that's my question. I mean, you're saying you give a patient a right to reject what was considered to be a marginal kidney. Will this counseling happen at the time of the offer, or at the time of enrollment, can they say, I'm not interested in an expanded kidney, I want a standard kidney and I'm willing to wait longer? Do you allow something like that?
Yes, so the consent process is quite elaborate and takes into consideration extended criteria donors. There's a scheme in the UK called the fast track kidney, which essentially kidneys which have been rejected by 3 centers automatically get fast tracked, so that the offer goes to all 20 centers or all centers which are registered on fast tracking. Now that could be because there was a CNS tumor, or there was a history of promiscuity, or perhaps a history of drug abuse. So these donors sort of get fast tracked. So these are the kind of things that we discuss at the time of putting the patient on the waiting list. Some centers even go as far as talking about CMV positive and CMV negative donors. And of course, the latest addition is hepatitis C, because obviously it's now become a curable disease.
Right. Any other questions from the audience? I'd like to thank you, Sanjay, for a very lucid talk. And we'll finally go on to our last speaker of the day, Matthew Wadsworth. Now, Matthew is the president and CEO at Life Connection of Ohio, which is an organ procurement organization. He started his career as an organ donation coordinator, and his OPO is listed as the top 3 among OPOs in his country, and in his tenure, he's helped to double organ donation rates. So I'd like to hand over the mic to Matthew Wadsworth, and who will tell us about organ sharing policies in the US.
Great, thank you very much. You see that okay?
Yes.
Yes,
you can see your slides.
All right. So thank you very much for having me. I really appreciate the opportunities to speak to you today and be a resource in any way that I possibly can. So yes, I'm the president and CEO of Life Connection Ohio. To give you an idea of our size, we only service about 2.3 million people. We're one of the 57 OPOs in the country. That size puts us about 51st. We do about 81 donors per million population, 246 organs transplanted per million population, and 34% of our donors are DCD. Within that 2.3 million population, we'll have about 350 donation conversations with an authorization rate just over 72%. So that gives you an idea of our size. This is what the 57 OPOs, or organ procurement organizations, look like. Their territories highlighted. Life Connection of Ohio, we're over here. As you can see, we have about 4 here in the state of Ohio, but if you were to go up to another state like Minnesota, they cover this large landmass, including 2 other states. This will come into play a little bit later when I talk about allocation. Some of these service areas don't make as much sense as others. For example, down here in Texas, you can see this green service area is actually spaced out throughout the state, which does create some logistical challenges and also some inefficiencies. They said, here's Life Connection Ohio right here in the purple, so you have an idea where we're at. I'm currently down here in the southern part of it. We maintain 2 offices. So the system in the United States really came about 1984 under this National Organ Transplant Act that was passed, which developed the Organ Procurement Transplant Network, and then awarded a contract to UNOS, or United Network for Organ Sharing, and they're tasked with managing our national waiting list, matching donors and recipients, maintaining the database. So our transplant partners will, register their recipients into the database there, so that we can do electronic matching. They develop our allocation policies, which is what we'll talk about today. And then they police us to make sure that we're following these policies. I'd asked a question earlier about kind of expedited allocation. And then we just heard in the UK, after 3 transplant programs have declined the kidney, it's interesting, it goes to a kind of a fast track matching system. There are times where we will allocate outside of traditional policy, even allocate thoracic organs, particularly lungs, to Canada in order to prevent an organ from being wasted. And then they're also not responsible, but they participate in transplant education for the public. So our allocation system has evolved quite a bit over time. Sounds like similar to UK, we just had a change in kidney allocation, which I'll talk about. A couple of years ago, our thoracic allocation changed. Originally, when I first entered the space, there's a lot of focus put on your local transplant center, then your region, and then your national list. Now we allocate more through acuity circles. The general rule for allocation is the sickest and the closest. I don't go into the detail of the scoring in this presentation, but on the last slide, I do provide a link that'll take you to the different calculators and how points are calculated. So again, just back to this country, our country, you can see that under the old system, we would allocate locally within our service area, our DSA. Now this could be dependent on, this could change from DSA. You might have multiple transplant programs. You heard from our transplant program earlier. Dr. Yadev spoke. He's from the University of Toledo. That's our sole transplant program. They do kidney and they start a pancreas program. And then we would allocate out to our region, which is made up of, our state, Michigan, Indiana, and then we would move to a national list based on the scores. But now we're allocating more through these acuity circles with different statuses assigned, particularly for heart. The same for lungs, based on medical urgency. The center of the bullseye would be the donor hospital, and then moving out 25 nautical miles from 500 to 1,000, 1,500, 2,500, and then greater than 2,500 for the national list, keeping into account how sick the recipients are and prioritizing them within each circle. Same thing for lungs, looking at 6 different zones, increasing by 500 miles. With the center again being the donor hospital and the priority being the sickest and closest. Liver is a little bit different, taking into account MELD score. So you look at your status 1As, status 1Bs, and again, moving from the acuity circles now have changed to 150 miles, 250 miles, and 500 miles, and similar strategy to keep the organ with as close as possible. We do not put any emphasis on one being DCD versus brain dead kidney, for example, or liver. I guess in this case, it's still allocated through the same methodology, not prioritizing the type of donor the organ came from. Kidney was previously offered through local DSA. Dr. Yadev said that, listed that they had one of the shortest wait times in the country. We were one of the higher performing OPOs across the country. But now that we've moved to this different allocation system for kidney, looking at 250 nautical miles, each dot represents a transplant program. So where we would allocate here first, and they would have essentially first dibs on all of our kidneys within our service area. We now have exposure to all these transplant programs shown here at the very beginning of our allocation. We continue to move and change our allocation policy in order to make it more equitable for people to receive organs. But if you look at the performance of our organizations, of those 57 OPOs, there's about a 450% variance between the higher performing organizations and lower performing organizations. So the argument could be made, maybe it's not necessarily how we're slicing the pie, but maybe we're just not we need to focus more on making the pie bigger. So that's very brief. Here's the link for the different calculators and take you to the UNOS website. And there's my contact information if I can serve as a resource at all moving forward. Thank you.
Thank you, Matthew, for that brief overview of how organs are shared in America. And just one thing that maybe I missed in your presentation, do states and OPOs get to make their own rules, or do they all function under the rules of UNOS?
We all function under the rules of UNOS. And those service areas that are given to us that we cover are mandated by the federal government. So the hospitals that fall within our service area on that map, for example, they're told by the federal government that this is the organization that you work with for your organ donation services.
So I have a question, Dr. Jamal, if you permit.
Yeah, please. Welcome.
Yeah, do you consider sodium mailed or mailed for allocation?
I think sodium is calculated within the MELD calculator. Is that the question?
Do you consider the mailed sodium? Like a UK system is having a sodium UK system where liver allocation happens because it is considered as a hyponatremia is one of the detrimental factor for the survival of the recipient. So those patients who are male, say for example, male could be 15, but sodium male could be 20 or 21 or so. So do you have the incorporation of the sodium as a factor in allocation system or not? Liver allocation.
I will pull that up and answer your question. I do not know, but I've got access to.
Yeah, I can help with the answer. Yeah, we do factor that.
Yeah. And second, what is the policy about splitting liver and how do we allocate the split liver?
How do we look at, a split liver?
Yes.
We'll allocate, so we'll allocate through the list normal and see, they'll on the match run, it'll say whether the patient would be able to just take a lobe. And if we're able to place one lobe of the liver, then we'll continue to allocate down. We'll bypass all patients that need a whole liver and try to allocate solely the lobe. It's also a circumstance where I mentioned we might allocate outside the traditional system. So if we're able to place one lobe with the transplant program, we might find ourselves in a situation where we might pick up the phone and call an aggressive center that's more likely to use that other lobe versus waiting 8 to 12 hours to allocate the other lobe and possibly lose lungs for transplant.
Thank you.
Thank you.
Right. I'd welcome any other questions from the audience.
Maybe if time permits, one more question. And do you have the machine perfusion followed by allocation, or usually the machine perfusion of the organ is done only at the local center?
So our organization, for kidney specifically, I'm assuming, our organization maintains kidney pumps and staff that will pump those kidneys while we allocate them. If the transplant program wants something pumped, we'll pump it. If they choose, if they want the organ just delivered right away for immediate transplant, we'll do that as well. So we maintain the resources and everything to do that if they request it, and we just provide that as a service.
Thank you again.
Thank you.
Right. Thank you for joining us, Matthew. And with that, I think we come to the end of the session, which has been very enlightening. And I think as surgeons, we need to broaden our horizons a little bit and understand a little bit about how organs are allotted and the evolution of organ allotment in our country. So with that, I'll hand the mic back to Ajay Oswal for closing comments, and then to Dr. Arun Chawla.
Thank you very much. I thank all the faculty members who have taken great trouble to make their presentations, especially videos, and make presentation on complicated subject like organ allocation policies. I thank all the audience members who have spared their valuable time on a weekend for participating in this session and keeping the activity lively by asking interesting questions. Over to you, Professor Chawla, for summing up the proceedings and closing remarks.
Thank you, Dr. Ajay. Just before I give the closing remarks, can I know Dr. Keshav and Dr. Rajiv Sudha, are they there?
Probably Keshav has gone, and
okay.
And I
fine.
Oh no, Dr.
Okay.
Rajiv Sudha is there.
Yeah. To conclude a very nicely scripted program on the deceased donor transplantation, I think it has achieved its purpose, and I think it has gone beyond that also, what I believe. A very nicely prepared presentations with video description of procedures from faculty to begin with Dr. Randeep, Anurag, Kunal, Jamal Rizvi, and Dr. Swaminathan has covered almost everything that one needs to know and be aware in the deceased donor transplantations. I think the young urologists and the residents would have learned a lot in the correct way of harvesting the retrieval with attention to prevent the collateral injuries to the organ as well as the vessels, the correct way of storage, packing and transport, and the bench preparation of the deceased donor kidney. I think excellent videos were there to learn the techniques of liver transplant. Not only the videos in the first session, but the questions from the chat box, the common situations, the uncommon situations in the chat, the questions, the answers by the faculty, and the tips and tricks from the experts were priceless. I think that made the whole of the subject complete. The second session was on the organ allocation policies, and we were enlightened by the excellent presentations from Dr. Vasanti, Dr. Astrid Lobo, Pranjal Modi, Sanjay, and Matthew Wordsworth. Overall, a very informative and very cogent webinar by the Renal Transplant Subspecialty of the USI, led by Dr. Ajay Oswal and his team members, Dr. Vasudevan, Dr. Jamal, Dr. Vikas, and Sanjay Sharikha. Dr. Ajay Oswal has always something different to offer in his webinars, and he did it quite nicely at this time. We had a little bit short or the word time, but I think it was the webinar was valuable, especially for those who had interest in the subspecialty of renal transplant. But congratulations to Dr. Ajay Oswal and his team. And thanks to all the international faculty and the national faculty who have prepared, I think, very well for their excellent videos which they presented today. And the team members from the second session who spoke about the administrative procedures and the allocation policies in the second session. Excellent. So overall, a very an excellent webinar and a nice Saturday evening well spent on the academic feast on the transplant specialty. Thanks to Navneet and Kiran for their logistic support. Without their help, I think all our webinars are always you can say under them. May I now hand over to Dr. Rajiv Sood for his concluding remarks, and then we can sign off. Dr.
Thank
Sood,
you,
are
Dr.
there?
Arun.
Yeah, please go ahead, sir.
Thank you, Dr. Arun. This was
Yeah.
wonderful webinar, and what was expected, that has been done. It is the Dr. Oswal is to be congratulated for this wonderful effort, and as usual, the subspecialty, each subspecialty is doing wonderful and wonderfully good for the promotion of urological practices, subspecialties in India, and this webinar it was timely. It was contemporary requirements of cadaveric transplant, and the basics have been so well explained from the legal point of view, from the skill point of view, in the videos, in the lectures, all the aspects have been covered. Nothing has remained uncovered. And Dr. Arun Chavla has rightly thanked each and everybody. And this was a long seminar, webinar, where everybody was glued to the screen, and it is going to be the treasure, this webinar in our USI archives, and anybody can view it again whenever in the leisure time, unedited. And I think Dr. Arun Chavla has promised that he is going to give us the edited versions also, and the effort is going on. Our mission of Indian School of Urology is on the right path, and this subspecialty is doing exceptionally well. Thank you, Dr. Ajay Oswal. Thank you all the faculty, Indian faculty, and especially the faculty from abroad, from US and UK, and each one has contributed immensely, and we hope that the future of cadaveric transplant is bright in India. India has a large population, and I know the one thing, that the male gender is the large population, the large source for cadaveric donors, because road traffic accidents, occupational place accidents, everywhere the male mortality in these brain death patients is large, and we have to motivate our community. We are multi-ethnic, multi-religious country, and various beliefs are there, and we will overcome that with all combined effort. We are in the right direction. We have a large demand, huge demand, and large pool of patients on dialysis. They are to be helped, and this webinar will give us the hope that more and more urologists will take up the subspecialty of renal transplant, and it will help our national health program. Thank you very much for this effort. Thank you very much all the technical team, and also thanks to all the viewers and all the delegates, all the participants, all the faculty, and everybody who has made the efforts to present the edited videos, lectures, and made this program hugely successful program. Thank you very much. Thank you. Good night.
Thank you, sir. Thank you, everyone. Thank you, Randeep. Thank you, Ajay. Thank you, Dr. Anurag. Pranjal, thanks. Jamal, thanks. Dr. Sanjay Sinha, thank you very much.
Thank you. Bye-bye. Thanks. Bye.
Good night.
Thank you. Good night.